the allocation, especially for devolution purposes, has not been something good. There have been a tug of war between the national government and the county government in terms of the allocation and whether the money reaches to these counties. And after this, we find one of the areas that is suffering most is health, and some of the counties we lack medicine and such kind of thing. But I believe we can have like a centralized system where this information can be put together. Citizens can have input in terms of how these systems can be improved. I think we can be able to improve a lot in terms of service delivery. But now the challenge is how can we be able to put together citizens' views, and on the other side, how can we bring all the stakeholders together such that they can be able to sit down and be able to know how they can be able to harness on technology? Because I think that's the only way, one, in terms of providing cheap way to provide these services. I think it has proved that it's an effective way. But now we haven't explored more, haven't done analysis or research to get to see how the government can be able to harness on digitization of this process. So if this can be achieved, bring stakeholders together, I believe we can be able to make health affordable to wananchi.
Thank you very much. Thank you, Dr. James. John, coming back to you, and thank you so much for the great work you're doing at IBP and IBP, even at the global level. Actually, I must mention that I'm one of the beneficiaries of some of your trainings, especially on budget advocacy. We know Kenya is a signatory to the Abuja Declaration signed in 2001, which they pledged to allocate at least 15% of our national budget towards health. Last I checked, I don't want to mention where we are, but do you think as a government, as a country, do you think we are making deliberate efforts to put adequate resources towards health? And now we're talking about the third time we are launching UHC. We have now the digital health. We have so many things going around. Do you think we are deliberately making efforts to ensure that the health bucket is adequately resourced?
Thanks. So, as I said a bit earlier, the prioritization aspect of health has been very clear, even in the public domain, that the government is focused on making sure that health is a priority. And this is one of the few times that we have seen a priority shift between governments, right? So most governments come and start their own thing altogether. But the UHC one seems to be one that, even the current government has picked up from what we had previously in the Big Four. Now, when you look at the resourcing side, I would say, when you look at the numbers in terms of where we are allocating resources, definitely the government is also putting its money where the mouth is. If you look at 2013, 2014, when we were just devolving, and you combine county budgets and the national budget, remember each level of government is doing their own budget separately. The proportion of that total combined budget that was going to health was about 5.5%. If you come up to where we get to 2021, that share had gone up to 11.1%. So in 10 years, or in just under 10 years, we almost doubled the share of our budget that is allocated to health, which I think is a really good thing. And health is the only sector of the 10 sectors that we have seen that consistent increase over time. Infrastructure was up one time, now it's dropped. But health definitely is one of the areas where we have seen that consistent in terms of the resources that are going to the sector. So we are still below 15%. I was just doing some quick math when I arrived. And for this year, 2023-2024, that proportion is at 10%. So we are somewhere, but not at 15% yet. But there is a caveat.
And I think we will get to 15%?
We might get to 15%, but I always encourage colleagues that whenever we are thinking about budgets, it's always good to remember that we do budgets annually.
Yeah.
And the reason why we do budgets annually is because every year we are thinking and rethinking our priorities. If our priorities are heavily infrastructure, the budget will always be higher for those priorities. If our priorities are heavily recurrent, our share of our budget will almost be lower than when it was heavily recurrent. Capital in nature. But the caveat I want to put in here is that the health sector also happens to be one of the sectors that has the highest fluctuations when it comes to what the supplementary budget does to budgets. If you go back a couple of years, 4 or 5 years from this year, you notice a lot of shifts. So as I said, that the allocation point is going up. But when you come to EMEA during the implementation time, the health sector is one of the sectors that is heavily affected by shifts. So money is moved in and out during the implementation period. And I think that for me is a concern which we can pay attention to. Let me give a good example. Last week, the National Treasury tabled a supplementary budget in the National Assembly. As you can imagine, the health sector is one of the sectors that the budget is getting cut. And even to be more particular, there is a line now, there's a budget line for digital health to keep in mind, so that if resources are being put in these places, we make sure those resources are actually spent as they were approved. But as the challenges you gave at the beginning happen, then it means this kind of changes are bound to happen. The question is, how do we make sure that areas of priority like what we are discussing today then remain within the budget and not the areas that get a cut? So as health practitioners, my encouragement, please don't just engage with Daktari and the Ministry of Health. Also focus on what the National Treasury is doing, because a lot of these budget and financing discussions also have a very heavy hand from the National Treasury, and of course the guys who make the final decision, which is the National Assembly.
True, and I agree with you. And I think it's also important to mention in this forum that for the very first time we had an opportunity to participate in the supplementary budget review. It was happening, I think, for the first time since devolution. And we hope that even the current supplementary budget will be subjected to public participation so that we can continue to defend the health budget. So, Daktari, maybe back to you, and just in a nutshell, because now we've seen, and from what John is telling us, the health budget has been going up, and there's attention that is being given to the sector. But now we're talking about digital health, and you see, digital health is just a sub-component in the health sector. And health is a devolved function as well. Do you see, in your own opinion, do you see the digital health getting the attention that the health sector seems to be getting with the UHC?
I think there is a challenge there, because for it to work, wananchi have to embrace it. So awareness level is quite low, based on the some surveys that we have conducted. So we have to start from the grassroots to get to have the citizen aware. How do they use? If they are able to use the M-Pesa and all that, can they be able to use the platform to do whatever they want to do? So these are some of the questions that we have to think. As developers, whom I think they can also help in one or another, how can they simplify these applications such that even my grandmother in the village can be able to have access to this platform? So these are some of the questions that need to be done. Now on the other side, in terms of budget allocation, I think that's also a challenge. One, how much do the county who have allowance in terms of how health is managed, how much do they get? And whatever they get, how much do they put into making this possible? Because even within health, and one of the issues that have been raised is, one, there's a lot of corruption. As in, you find a lot of money has been put into a certain sector, but you find when it comes to accountability, it's at zero level. So these are some of the challenges that we need to face, not just looking at what need to be done, but who is doing this, how accountable is this person. Now on the citizen side, are they accountable in terms of putting these people on their toes, such that they can be able to deliver on what they promised? So when we are able to do this, I think we'll be able now to make this work. And not only that, even we'll be able to attract other people, other stakeholders to come on board, because I believe we have this private-public partnership, which I think can help us be able to make this work. How has the government made it possible for these people to come together? Because if it's only the government that's going to do this, then I don't think we'll be able to make it work. Because one, they have, in terms of budget allocation, we have challenges. We've heard about their budget declaration. We're supposed to put 15% of our budget allocation into health. That has not been achieved so far. So what can we be able to do this? We have to bring all the stakeholders on board such that we can be able to address this. And on the other side, and citizens, in most cases, citizens are always forgotten. If you're able to come up with this system without involving them, I don't think we'll be able to have this work in the near future. But if we are able to adopt and decide to change how we have been doing things, then I think it will work.
Thank you, Dr. Thank you very much. And you've alluded to my next question to Kennedy on the PPP model. And we know that we have a framework that we developed as a country on the PPPs, which has been a challenge. Do you think from the Medical Credit Fund and from you as a practitioner in the private sector, how do you see that collaboration between the private sector and the public in terms of PPP, bridging the financing gap? Yeah, and we've seen, and from what John is telling us, and even Dr. there's a resource gap in the health sector, and more specifically now to the digital health, because I don't know how many counties, we had some very beautiful stories here from Murang'a and the rest, but is that the same in all the 47 counties? Yeah, so how do you see that PPP model bridging that resourcing gap? And how can that be made more effective so that the citizens of Kenya can benefit from this new frontier of digital health?
Thank you. If I take you back to that village in Kangema, where I said 9 out of 10 people are billionaires, it's the same village that in the 21st century we're still struggling to eradicate jiggers. So the question is, what are these 9 billionaires doing in their small village to affect the other people that they are living together with? It's the same structure that the government is currently struggling with the PPP, if you put it in a layman's term. The public sector is trying to do this, the private sector is trying to do this, government is trying to do this. At what point do we marry all these three to ensure that we are speaking the same language? Because at the end of the day, when Kennedy is sick, Kennedy is neither public, private, or government. Kennedy is sick. It's an individual. It's a human being. And unfortunately, health is one thing that we cannot keep on the side. We can keep aside construction of roads, construction of dams, and all that. But to treat somebody who is sick, we cannot put it aside. You can forego to fuel your car today, but if your child is sick today, you will do all things necessary to ensure that kid goes to the hospital or gets the right treatment. So currently we're struggling because everybody is pulling on their own direction, whereas we are trying to achieve universal health care. It doesn't matter which side you've gone to get the treatment. It doesn't matter whether there's a public hospital or there's a private hospital. What you need is to get treatment. What you need is to ensure that you are healthy at the end of the day, to be able to give back to society. You can only do this if you are healthy. So on the digital health transform, what we need to ensure is all these things are speaking the same language. What do I mean by this? For example, if you are at Kencom this morning, you will find 60% of people holding envelopes of things that have been given by doctors from wherever they're coming with. They're headed to Kenyatta with all these envelopes. And you ask yourself, this item that is inside this envelope, an X-ray or whatever, it was taken by a digital machine. Why do you subject this old woman into all this 3-hour journey to Kenyatta Hospital? Why can't you send this as a doctor digitally to the other doctor? They are able to look, read, and advise you as a doctor there in the village and tell this old person, this is what you need to do. You don't need to travel all the way to Kenyatta, queue for 4 hours, just for somebody to look at that and tell you XYZ. That will have been sent. So if I'm able to send money today to my grandmother in the village, why can't health also be done in the same format? Simply because, in this instance, I'll actually accuse the healthcare practitioners. People are becoming mean on data and information. Simply because you want Kennedy to continue coming to your facility and not to go any other facility. You don't want to avail this data in a format that's available to everyone. I am the only one who is sick. I'm the one who's supposed to give you like a click button and tell you if you press this, you're able to get all of my information. We've had scenarios, for example, where somebody is involved in a road accident. You are taken to the nearest hospital. They don't even know your blood group. At that moment, you're unconscious. So we end up losing a life that will have simply been saved if information was available. For example, in a digital format. If something happens to me, you just need to take my thumbprint and put it somewhere, and then you'll be able to see them. Doctors have seen since I was born, whatever they have prescribed. how are we able to bring all these sectors to speak the same language? Why is it that Kisumu is implementing a different UHC than Murang'a? Is it that the people in Murang'a and the people in Kisumu are different? Why is it that Tana River is not even a priority for them to do UHC? Their priority is already something else different. We need to have a national government that carries all this and cuts across to ensure that if the county government are going to implement X, Y, Z, let it be universal. I could be a private player, you could be a public player, but at the end of the day, it's health that we are looking at. Thank you.
Just still on your Kennedy, I know private sector is been known to be very, very innovative. And maybe in your, because I know you coordinate programs across East Africa, and that with that international background, have you seen some models that we could borrow from as a country to make the resourcing for health or financing for health work better for Kenya? And some lessons that we can also draw from such experiences?
The digital transformation, what I need to say is that Kenya, we are well advanced by than a majority of the countries that we normally look up to. What do I mean by this? In all these other states that we look up to, the digital framework is slightly lower than ours. We are well advanced. And actually, a majority of these countries need to borrow from us. We don't need to borrow from them. The only thing that we lack as a country is putting the right resources in the right place. The private sector in Kenya only has all the available means, all the available things that we're speaking about here today. For example, there's a MyDawa app that you can now go in and request whatever you put in, your prescription, and you'll get the medicine delivered to your doorstep. This is not available in so many other countries. It's only in Rwanda where Zipline is actually working, where they're currently delivering drugs into the remote areas via drones and some models that they have created. All this is actually happening in Africa. That's not happening in the West. The only thing that the West has that's better than ours is actually infrastructure. That's why they are well developed than us. But digitally, we have all it takes, and I can tell you here today and now. We only need to stop being greedy. We need to stop looking at it's me. It needs to be ours. The moment it becomes ours, right from the national government to the county governments, to the public facilities that we're having, we have the best resources. Thank you.
True. And picking it from your last point on let's not be greedy. Dr. James, you know corruption, if you mention corruption anywhere in the world, I think the first country that comes to mind is Kenya. And we know what corruption has done to service delivery. We've heard of all the scandals, the Afia House scandal, and so many others. What do you think can be done to ensure that whatever little resources that we allocate to health are protected and well accounted for?
Allow me to step back a little bit and look at corruption. A majority of us normally look at corruption from monetary lens. Now, let's also put in something else, public participation. There's a lot of corruption. Because basically, and this is from experience, we have done a few surveys in a few counties, found that whenever there is a bill, let's say it's about health, implementation of UHC. So what normally happens is, there's this big booklet that is brought in. Maybe you're not you're informed tomorrow they'll be having such a thing. They require public participation. You have to put in your views so such that the budget allocation can prioritize ABCD and all that. Now, what happens is you select people that you know, people who are even not aware of whatever is happening. You bring them on board, they sign whatever and do all these things. And then the discussion starts. Probably, and this is something that is happening, the discussion normally starts at 3. Instead of starting early in the morning, they start at 3. And now, what is happening here, and citizens have complained a lot about it, it's like they're just there to endorse this. So what does it mean? Now, the citizens that we have, one, in terms of awareness, it's quite low. So whatever they are given, that big document, they can't be able to understand what's happening and all that. So if you look at corruption from a broader perspective, be able to understand it better and be able to find ways to tackle this. Now, It's quite difficult to put people into accountability if the information is not there. So one of the ways to address this is to promote awareness. Have an inclusive forum whereby you have all parties involved. And let me say this, even among us CSOs, I think there's some kind of greediness, some level of greediness, because I want to put this portfolio for myself without involving my colleague, of which if we work together, we can be able to address so many things together and even be able to complement one another. So if we start addressing corruption at our level, I believe a lot of the problems that we have can be solved. The same thing, like what my brother was mentioning here, it's like we have this county doing this and the other county is doing this. So if we can have a uniform way of implementing some of these policies, we can have a simpler way in terms of sharing information. Researchers can be able to dig deep and even come up with solution and eventually be able to find or to come up with models that, okay, we can't be able to have a corruption-proof models, but at least we can be able to minimize corruption at a certain level. So let's not just look at corruption from the monetary lens, let's look at it in a holistic way, and I believe there are solutions that we can be able to come up with and come up with a system that can be able to overcome these challenges.
Thank you, Dr. And John, to you, and still on the same question. I know budget documents or accessing the budget documents has been one of the greatest concerns that many, actually even in this room, I was having a chat with a few of us who are doing some budget advocacy, and accessing some of these documents is quite a challenge. So tied to the issue of transparency and accountability in terms of how we allocate our resources, what do you think can be done, especially from the citizen side, to safeguard public resources, and what do we need to do better as a country to ensure that there is transparency and accountability in our processes?
So I'll say, first of all, when you start right from the premise of how the healthcare sector is now organized in Kenya, so health is definitely it's actually the heaviest devolved function of government, which means then that counties play a big role, right? So even the discussion we are having in this room, the success of it will lie a lot with what counties do, even probably more than what the national government does. So that means we are constantly asking who is allocating what money for what functions when it comes to healthcare, and even in very specific subsectors and issues such as the digital health one. Now, at the national level, we've had over the years quite an easier time in terms of accessing budget information and on time. The only challenge remains that it's just up on the website, and the question always is, can every Kenyan access information through that model? At the county level, it's been a bit more of a challenge. As you said earlier, we run a survey every year looking at what information counties are putting out, and it's been quite low. But I think what we are seeing make a difference is when many of us are engaging with those budget, asking questions, trying to deal with some of the problems that Dr. has spoken to, where public participation is done but information is not provided. So people raising issues of why have you come to this discussion with us and you walked with the documents in the room right now. You should have given us those documents a week, 2 weeks ago. So those kind of everyday engagements are actually playing a big role beyond what civil society organizations do, from an advocacy point of view. And I think when it comes even to the accountability side of it, as I said at the beginning, all of us can engage with the budgets. Accountants and economists have lied to the world over the years. They are the only ones who understand budgets. That's not true. I think all of us have really a clear understanding of the priorities we care about. Many of us in this room have an idea of what it will take to fund immunization. That's what all budgets are about. It's not an accounting cash flow in, cash flow out, no. And so that means that the more we engage with national and county governments about what budgets for what, how is that money flowing from the national level going all the way to the service delivery levels, then that also becomes a point of accountability. The post-mortem days of doing social accountability, where the year would end and then we come with our notes and do a post-mortem of what happened and then say, corruption. I think we are changing our attitude as Kenyans from that to keeping track of what is happening with each decision that is happening within the budget process. So even the kind of conversations we've been hearing of late on budgeted corruption. If you're able to catch those issues when you're formulating the budget, then downstream processes also become a bit cleaner than what it would have been if we had not engaged with that. So for me, I think, first of all, paying attention on what will happen at the county level, especially on the discussion around digital health, I think is really important. This will sound petty. So when the digital health bill came out sometime in September, my colleagues in the office were like, how much weight is this bill putting on the role of counties? And one of my colleagues said, we should just do a search find of the document. And I think counties were mentioned just less than 20 times in that bill. Then as we continue doing the analysis, we realized there was an e-health bill that had actually been tabled in the Senate 2 months before that. And we did the same thing. And in the e-health bill, counties were mentioned 88 times. So both bills, if you look at what they have, is basically the same content. But it seems as we came to the digital one, we lost the word county quite a lot. So even as we're thinking about accountability, is who are we asking for what? Because who is funding what becomes a big, big conversation. So we need to keep going back to that Digital Health Act, looking at who is responsible for what. But at the end of the day, it's going to fall heavily on counties. So as we discuss the issue of social accountability and what citizens can do, we have to constantly ask, this level of government that runs 93-94% of the health facilities that are public in this country, how are budgets being done, how are they being spent, and not just at the end, but throughout the budgeting cycle. I think that is going to play a big role.
Very, very important. And budget process never stops. As I normally say, it's a cycle, never stops. So if you lose sight of any stage, you'll be left behind. So as we get to the tail end of our discussion, and we know digitization in the country must be driven by infrastructure. And the government has prioritized last mile connectivity as one of its key priority agenda. So, Kennedy, from where you sit, do you think, because we have, actually I just saw, before this panel, I just saw a survey by Siasa Place, and they were trying to look at, because government has been launching Wi-Fi hotspots in different counties, so they did a spot check, and out of the 17, only 8 were functional. So in terms of access to digital platform for the undeserved communities or populations, the far to reach places, do you think the government or with the last mile connectivity program will get to a point where it will say the country is fully connected to the internet?
Thank you. Connectivity to the internet will reach probably in another 10-20 years. But the problem will not be the government, the problem will be you and me. You and me, by virtue of the many hurdles that we are putting in terms of giving your information. It's only now that the Data Protection Act is coming into place, and you've seen the way people are being sued left, right, and center. And by virtue of this, everybody is starting to develop a cold feet. The information, again, that's there on the public domain, for example, today, if I go to the village and I start speaking to my old folks about some information on their mobile phone, it becomes a fight. So as the government is really trying to ensure that there's digital connectivity to everyone, I think the biggest thing that we also need to do is an education to ourselves. Because you have the power to put all this information, what you want, on the internet. And not everybody can access it without your right on what you give. But it reaches a point where this information is actually needed. And if you did take the opportunity to put it, in as much as we have the digital connectivity, we have the internet hotspots everywhere, and it's not being utilized, then all this will go actually into waste. The unfortunate bit is government shifts focus very fast. Right now we could be talking about digital connectivity. We don't know what will happen in the next 5 years. We don't know what their priority will be. So it's high time that now we took advantage of this, as those of us who know the powers that this connectivity has, to actually enlighten the others that need to know about this. Thank you.
Thank you very much. So I think our time is up, and I would request that we take just 30 seconds to make our final remarks. We're starting with John.
Thanks. I think for me a parting shot is, let's try as we think of how to finance digital health, not to silo it. Let's think of it in the broader sense of how government operates. Let's think of it in terms of how it takes advantage of this digital superhighway conversation. Let's think of it on how it takes advantage of other existing systems. I really like what Anne said about education and what kind of information is collected in those kind of levels. And let's try as much as we can to learn from systems and from approaches that have come before these ones. IFMIS, the the system we use for our money, right? So the integrated financial management system that is run by the National Treasury is a good place to learn on how it works and how it doesn't work. I think that's going to be an important one, because if we don't get it right and if we don't learn lessons, especially when we are thinking of something this countrywide, then we might lose important things. And a small snippet is to remember, even today with IFMIS, directors of budgets from counties still travel to Nairobi with folders to come to the office of the controller of budget to get things ticked before monies are disbursed to counties, and we have IFMIS. So let's learn lessons from it. So let's not silo it as a small conversation, because it's wider, and I think the potential impact of this is really great in terms of how we make decisions about priorities in health and how we make sure that we are accountable for all the resources that we spend in our healthcare system. Thank you.
Thank you, John. Dr.
Okay. As an advocate for citizens, I think we also have a problem. And probably the question that I want to ask is, among us, how many people have ever attended public baraza to discuss something, a bill on such kind of a thing? I believe it's less than 10%. So we are the people who are hindering some of these things from happening. One, in terms of knowledge, I think we are above average, of which we can use whatever we have at least to sensitize them, to educate them, not only just the citizen, even the policy makers that work at the county level. And I believe we can be able to start with ourselves. What budget do we put to promote awareness and all that in organization? So if we're able to address that, I believe we are going to make it happen. Thank you.
Thank you very much, Dr. Ken.
Over tea break, somebody told me that a member of parliament will preside over Harambee to build a hospital, but they will sneak to see a witch doctor at night. For us to be able to pay the loans that are due to us next year, as the opening statement was, we are due 2 billion. For us to be able to fuel our cars at 300 per litre, for us to be able to pay the 1.5 housing tax, and now what is coming in on NHIF at 2.75, we all need to be healthy. If we are not healthy, all these measures that are being put in place will not work for anyone. So it's very, very key that we take our health, or the country take the health of its citizens that is going to tax into oblivion, as a very key priority. And digital health will play a very key role in this. Thank you.
Please stay healthy. That's the last word. And I'll be taking, I don't know whether I have time for questions. Sorry? Okay, 2 questions. 1, please stay healthy.
Thank you very much. This is not question per se, but it's a comment and a clarification, and it goes directly to Okongo. Number 1 is that your comment of there is no drone in Kenya is a lie, and it should not be heard from people from Kisumu. I'm the director of medical services Kisumu County, and Kisumu has a zipline and drone technology delivering blood and anti-rabies, anti-venoms. So if you talk about Rwanda and you don't know what Kisumu is doing, and your name is Okongo, I'm worried. And Dr. Kizra will not forgive you for that. Okay, to go to the next clarification. Number 1, there is advantage of what we call devolution, and there is a disadvantage to devolution. One of the disadvantage of devolution you've talked about, there is no way health can give a clarification and everything is done throughout Kenya. Why? Because the government budgets and each county budgets according to their priority. So each county is unique on its own. So as of now, we are doing digitalization, which was again launched in Kericho. But if you go to a county like Wajir currently, where floods is now the main problem, do you think their budget, that they can use it for digitalization while people are dying because of floods? So what am I driving at? If you look at even in Kisumu budget for 2023-2024, and even for Murang'a we are talking about, there is none that has digital as one of their budget. And the only way to sustain this thing is to put it in budget. What is our problem? Our problem is that most of the time we depend on partners. And that is the reason why we were talking about different digital platform and ways to look into it of its interoperability. The reason why we have different platforms is because of most of these things are because of the partners. They are not enshrined in our budget. And budget is a public domain. You can Google the program-based budget for Kisumu. There is no digital health, but we are in digital health platform. If you do that for Murang'a, which I've checked right now, it's not there. It means that high likely their digital platform is from partners, and each partner will come with its own digital platform. So these are the problem. The money from the central government does not come for digital health. It comes to the county, and the county also budget on it. And the problem is digital health is also in the hands of politicians. And MCA, what you have talked about building an hospital, that is what they see, the brick and mortar, because it's a political tool. They want to build the facilities and not want to talk about digital, because how will you campaign that we have a digital health, and somebody will campaign, I brought for you a hospital. So those are the problem we have. These are just a clarification so that we understand what problems we have. Thank you.
To Europe. Next question.
Thank you. My name is Simon, our public health specialist. I wanted to ask, over the years we've been pushing for domestic financing. We know a lot of our programs are donor funded or partners come in, UHC, not PHC, HIV prevention, the research, the PrEP, all those are all donor funded. Are we able to see a future of domestic financing of these programs if we say some of the budgets, like for digital health, has been halved, is half as at now? Are we seeing a future? Is it a campaign futile that we are pushing for domestic financing of all our health programs and not depend on donors, PEPFAR and the Wellcome Trust and all these other donors who will one day fold up and go away?
Thank you. No way. The panel was purely men, now questions as no way. I'm not going to give this one is for ladies. Thank you. Thank you for rescuing us. Well,
I think mine is an ignorant question. My name is Angela from Farm Access, and I am wondering how far-fetched is it that the healthcare budget can be ring-fenced both from national and the county levels, so that there is no possibility of dipping into it.
Thank you. I think we'll take those three questions. You have a question? 30 seconds.
30 seconds. My question is, a digital platform gives the issue of accountability, and we have had always a problem of the counties not even posting their IDPs and CIDPs in the digital platform. Why don't we start with those low-lying fruits? What can we do to make it a practice for us to be digitally accountable? Thank you.
Digital accountability. My panelist, you have 2 minutes to respond to those questions. Thank you. Who wants to?
I think I'll start by addressing the question from Simon on the issue of donors. For the people who give, I believe they give because they have surplus. That's why they are able to donate to us, and in us we call them the international community. It's the same way I could have surplus and decide to donate to a school, a child in my village who needs school fees or something. So the question then arises is it that we never have surpluses for all the organizations that we have in Kenya, that they could be able to give back to our society? We have so many CSR activities that we normally take. A majority of them go through mostly tree planting and the like. I've never had a scenario where, for example, Safaricom has an excess and I've decided now today we are going to do this for health. We have the M-Pesa Academy and all those good things that are happening, but we don't have somebody locally who is able to give back to health. If I was to point an accusing finger to any organization that should be on priority one in giving back to health, that will be East African breweries, but unfortunately they don't do that. So the organizations that we have in Kenya that are not able to have surplus to give back to ourselves all ties back to us. What is it that we are doing wrongly that the other people are doing right? Because all these donors that we have internationally, you'll hear probably they are pension funds, probably they are just surpluses that people have kept in banks, and now they feel like we've earned enough surplus from this, let's give back to the community, which we are able to do that by ourselves. So it goes back to the question is, do we have ourselves as our priority? Must somebody always come into our house to give us something to enable us to be able to do X, Y, Z? Just to touch briefly on the question that Angela has asked, I'm not in the budgeting process, and I don't know how that ring fencing can actually happen. As Dr. Ganda has put it, they are given money by the national government. They are not told to use it on this and that. Then they have their own internal budgets. And I'm sure you are alluding to what John had said, that media, a supplementary budget comes in, and what was allocated to health, instead of it being increased, again, is taken downwards. That just tells you that actually health is not a priority to us. It's only the stakeholders who can come in and sit and say, once this money is allocated to health, let it purely be for health. Thank you.
Thank you. John. Okay, Dr.
Yeah, on the drive to make counties share data and such kind of stuff, it's a bit difficult, although we have a way in which we are trying to make county governments aware. Kenya is a signatory of a movement called OGP, Open Government Partnership, and we also have it at some national level. It's a drive. We are trying to recruit more counties to subscribe to this, such that one of the agenda is to make public some of this information. The moment they subscribe to this, we have now NGO people who normally follow, whether you said you're going to do this, for you to be part of this, you have to have this and this shared publicly and all that. So it's through that we can be able to have most of these counties be able to share this. But without that, it might be a little bit difficult because we have tried before. But from another perspective, we can be able to have them beside signatory to this and be able to share this kind of data publicly.
Thank you. John.
Quick one, and I'll start with Angela's question. Your question is not ignorant at all. I think it's a concern that many players in different sectors have on how do we make sure that the resources that are allocated to a particular issue actually remain to fund that issue. There are pros and cons to it. The pros is that the money remains. The cons is that anytime there is a discussion around budgets, then whatever is ring-fenced, so you have your money, go away. Let's discuss with the others, because you guys have your little thing. The Women Fund is the best example of this, right? So the Women Fund, the Youth Fund, if you combine them, they come to less than, it's around 30 billion shillings a year. So when women go to ask for money, what are they told? You have your fund. So go away, wacha tusukumane na hizi vitu zingine. And our budget is 3.6 trillion shillings. So you are left haggling around 30 billion shillings. And then the conversation about the distribution of the rest then seems to be something that you're not allowed to have a discussion around. So there are pros and cons to it. But I know in the health sector, it's one place I've had the word ring fencing a lot. Nutrition guys want ring fenced. Immunization guys, ring fence ours. Ramka guys, ring fence ours, please. so there's a conversation that is very live in there, but it has pros and cons to it. So I would say that the goal probably is going more to what James has said. You want to really just be present. engage with the budget. Let any time a supplementary is being proposed, the Ministry of Health, the Director of Health from Kisumu knows, the guys working in health in Kisumu will be on my neck if this line is moved. Domestic funding, we have no choice. I think if you look around the world, and my knowledge here might be a bit limited, but in countries where UHC has worked well, it has been heavily driven by government funding. So you want to see that proportion of government funding going up. And the good thing with Kenya, the last Ministry of Health presentation I saw on this, actually our proportion of government funding is actually going up, which I think is a good thing. I don't know what these 4 bills we've passed will do to that, but I know that that is something that as Kenya we are coming to. Because of our lower middle income status, the donors are automatically leaving. So that is something that I think we have to keep attention to. How much is the government putting in? And remember, we are still a very poor country. You know, we talk a lot about how the public can be mandated to, 39.6% of Kenyans are poor, right? So who is going to fund the health care for the poor and the vulnerable? Still going to be very heavily driven by domestic resources that most likely are going to be resources from government. And the last one, I'll just agree with the director from Kisumu, MCAs. Let's do everything we can to make sure MCAs understand the things we are talking about. 3 years ago, we did a research across the 47 counties on reallocations of budgets. Health, agriculture, their budgets were always cut down. These are across 5 years. The budgets for health and education, for health and agriculture were going down. Guess which ones were always going up? Roads and water, right? Because water, borehole. Water, dam. Water, a water pump somewhere. Roads, barabara, culvert, those nice pavements. For those of you who are from Eldoret like me, there's a pavement from town almost to the airport. You know, so that's something that people. So we need MCAs to understand, because at the end of the day, all these technical conversations we are having are an annex to a political discussion by MCAs and by members of parliament. So let's aim to make sure that our politicians understand, exactly as he put it, why there is value in doing XYZ that is not necessarily brick and mortar. Thank you.
Thank you very much. Please, you can tell that this is where the heart is. It's been quite intense conversation. We apologize, we have overshot our time. I would request my panelists, first please, we deserve some claps. Thank you. And then I'll request the cameraman, as we prepare to step down, we'll take a photo with the panelist. Thereafter, we shall make the next announcement. Thank you. Thank you so much, Kennedy Okong, Dr. James Siara, and John Kinovia. My name is Osedo Stephen. Okay, thank you. Tuwapigie makofi wakiambaka tafadhali. Allow me to put on the other jacket, and right about now we are going to take a break for lunch. I guess lunch will be served at the main restaurant. No? Oh, I'm told you turn right. Trevor, you may want to make that announcement. Oh, it's you. Okay.
Hello everyone. So because of the rain, the lunch has been brought a bit nearer. So on your right, you'll see a big white tent. That's where we'll be taking our lunch. So please make sure you pick a meal card as you leave before you go for lunch.
Timekeeper, how many minutes do we have? Now that it's brought nearer, we can take 45 minutes? 45 minutes. Please, let's be back by 2 p.m. 2 p.m. Okay? Enjoy your lunch. Asanteni. Tujipigie makofi tafadhali. afternoon. Good afternoon. I hope we enjoyed our lunch and now re-energized to take on this final lap of our conference. So, to start us off, I'd like to call upon Winnie Gift. Winnie, let's put our hands together for Winnie. I'd like to call upon Winnie Gift to come on stage and introduce her panelists. And you have 30 minutes to discuss the community of practice, leveraging community networks, movement building for digital health rights advocacy. This is a very interesting discussion, so please let's pay attention. We're still going to use our Mentimeter for discussions, clarifications, questions, and everything else. Winnie, your 30 minutes started 1 minute ago. Karibu sana.
Good afternoon. My name is Winnie Gift. I work at KELIN at the Strategic Litigation Thematic, as well as I'm a member of the KCAT, the Kenya Community Advisory Team on Digital Health Rights Project. So I would like to invite my able team on stage. First of all, I'll start with Victor Karaoke. So Victor Karaoke is a community health advocate. Currently, he's chairing for African Bureau Advocacy Influencers at the AHF, which is the AIDS Healthcare Foundation. Kindly help me to welcome Victor on stage. Thank you, Victor. I would like to invite our next panelist. Some of you might recognize her from the popular reality TV show, Miss President. Her name is Jacqueline Aweru, but some of us still call her Miss President. Jacqueline is currently manages the Students Education Fund under the Community Health Promotion Fund. She is the team lead of Leadership Impact and also currently sits in the Y Act Youth Steering Committee. She's also a fellow member of the KCAT. Welcome on stage, Jackie. Thank you, Jackie. So our next panelist is Enosa Adera. Enosa Adera is a motivated community social mobilizer associate. Enosa Adera serves at the Strategic Communication Department for National Transgender Advocacy Network. He is also currently the Program Officer at Trans Alliance Kenya and also a fellow member of the KCAT. Help me to welcome Enosa on stage. Thank you, Enosa. Next we have Michelle Oluoch. Michelle Oluoch is the Program Officer, Policy Advocacy and Rights Digital Health at the One-to-One Youth. Kindly help me to welcome Michelle on stage. And finally, we have James Kielu. James Kielu is a medical student, particularly focusing on SRHR, public health, and oncology at the University of Nairobi, where he currently serves as the secretary of the Public Health Club. He's also a youth advocate at the Center for Study of Adolescents. He is also the director of outreach at the Integrated Cancer Research Foundation and also a member of the KCAT. help me welcome Jim. So, thank you to my able panelists for joining the stage. Today, we will try to be extremely brief because we are behind time. Our presentation will be on leveraging community networks and movement building for digital health rights advocacy. On stage, we have, particularly we'll be focusing on minority groups, and we'll be focusing on key populations. We have representation of the young people, we have representation of HIV community, we also have representation of the LGBTQI community. So I'm sure that this is going to be an engaging conversation. So I think we can kickstart. I'd allow them to introduce themselves afresh, but in the interest of time, I think we will just go ahead to begin our panel discussion. So we've been discussing a lot yesterday, and we continue to discuss today on the potential of digital health, revolutionizing the way healthcare is delivered. So as we celebrate the impacts of digital health, we also have to realize that there are some challenges and ethical considerations associated with the implementation of these digital solutions. So we really have to figure out what do we do about these challenges. So our able team here is going to help us answer some of this question. This panel seeks to delve into the changes in advocacy strategies that members of the community of practice have adapted to ensure mitigation of impacts that the speedy uptake of technology and regulation have on the youth, marginalized minority, and key populations. So I'll start with you, James. Just a minute, sorry for the delay. So we'll begin our panel discussion with you, James Kielu. So my first question would be, I know all of your organizations and also you on individual levels have been engaged in health rights advocacies, reaching out to diverse populations, including the youth and key populations. So what are some of the strategies that you have employed or you have witnessed being employed in your various organizations, and in your opinion have worked over the years in the realization of universal health coverage?
Hello. Okay, thank you. Thank you very much. So basically what we have been trying is to convert the theory into practice of how to build a grassroots demand for UHC in our communities in the spirit of ensuring that nobody is left behind in the uptake. And so there are some populations who will have certain tendencies to be left behind in this transformation. We are talking about people living with disabilities, people living in far to rich areas. And the reason which might lead to people being left behind necessarily is not about internet coverage or infrastructure, but what has been described as paucity of knowledge in the society about what we need to do to achieve UHC. So what we do is that we go to the community and build this grassroots demand, let people know what is UHC, how can we achieve UHC, because UHC are basically 3 components, ensuring that people have increased access to services, financial cushion, and then improving quality. So access starts from people knowing about services which are offered, starting at the community level, from the point of PHC, going upward the healthcare system. So we go to the community and hold advocacy sessions. So for us in CSI, we mainly focus with sexual and reproductive matters, where we work with adolescents to inform them about different sexuality issues, and that is a first point of contact with the healthcare system, education. as a mode of prevention to ensure that we don't escalate the problem. Another thing, when we try to engage now the decision makers, we also try to link these issues to the commitments which they have made internationally and also locally, and to the provisions of our legal and policy framework. You say, this is what you should do, this is what we expect you to do, this is what the people demand you to do. Thank you.
You're welcome. Michelle Ulwoch, what are some of the strategies that you have employed?
Thanks. Just to clarify that one-to-one youth is the, what is happening? One-to-one youth is the youth department within University Health. Okay, so yeah, I was just clarifying that one-to-one youth is the youth department within the NGO called LVCT Health. So as LVCT, we've employed different strategies. As we know that somebody pointed out even earlier, that health has greatly been devolved. And so in one-to-one, we work with adolescents and young people, obviously. And as he has also pointed out, we work with the marginalized communities or minority communities. So HIV, so that's adolescents living with HIV, PWDs, and sexual minorities, the LGBTQI plus community. And all of these groups have very different, or rather they have ways in which you need to be able to cater to them. Because we know that an adult or an older person living with HIV and an adolescent, as was being pointed out earlier, does not have the same requirements. So we work a lot with county governments, where we're able to support even with strategies. For example, more recent one in Kilifi and Mombasa counties, where the AYP strategy is, or policy rather, so that you can be able to make sure that these groups of people are catered for. Do we actually have something that is, talking and speaking to these particular people? It's not just a general thing, because even as we were talking about the digital health, the law that came in and the Health Act and all these other things, these still need to come and be localized into the local communities. So we work a lot with the county governments, the CECs that are within there, just to make sure that this group of people are catered for, and at the end of the day, there's somebody, actually a voice for them. We also work along with youth advisory champions. Some people call them YAC or YACs, YACH. It's the Youth Advisory Champions for Health. And we try to empower these young people, because usually they're from 18 to 24. And we want to make sure that these young people are actually within TWGs, that's the technical working groups, for health, that speak for their specific health matters. Because who better to advocate for their health than the persons themselves? So it's more practical, instead of having somebody who is, a mature adolescent, 35 plus, coming and talking on behalf of somebody who's 18 to 24. So there's those different strategies that we just try to make sure that there's proper representation for the people who it actually affects. And we just don't throw them into it. There's training that is done so that they know how to advocate. Of course, at the end of the day, they may choose which thematic area they want to go for, but what you focus mainly on is HIV, sexual reproductive health rights, mental health, and gender-based violence prevention and response. So these young people then can be able to get whatever niche that they want to respond to, and they can advocate for their rights and their peers' rights through the different forums that try to get into opportunities with working with other partners as well.
Okay, thank you. Good afternoon, everybody. I'm very happy that this particular conversation is coming timely, and this conversation has also been informed by some particular work that was done, be it a survey or research, because there was a problem somewhere. And in the same regard, as Trans Alliance, our main mandate is to advance and protect all human rights, looking at the civic and political, cultural, economic, and all that right that is enshrined to a human being. And we are looking at this perspective by building knowledge, empowering right holders, sustaining dialogue in our community. And these are very, very critical to advance human rights of the trans persons, to advance rights of intersex individuals, and also to advance rights of gender non-conforming persons. And if you look at the UHC conversation of leaving no one behind, making health a business for everybody, we as Trans Alliance and also GC Young at the national level, we commissioned a research 2019 so that we are also able to engage with an evidenced paperwork. And this was looking at the issues around, looking at the equalities issues around education, looking at health perspective, employment, looking at political and participation, and also lastly looking at legal recognition in that particular perspective. And I have to appreciate the Minister of Health in this country for always holding the community at heart, because when we had the product of this particular research and starting the engagement with the government itself, it has been not that hard. I say they're very supportive, including the State Department of Gender. And if you look at building knowledge, our main focus is to look at how can we create this particular demand in the community. Do community members aware of the different services that are offered in the mainstream institutions? Because at the end of the day, we are speaking of inclusion. We are speaking of service to everybody. Are they aware of these particular services that are being offered in the health facility? And if you look at the product and the outcome of this research, there were a lot of items that were coming across discrimination, across handling inhuman and disrespect handling from the health service providers, of which we started engaging, because as a matter of a fact, we have to start from somewhere. And that's why we are here today, because I believe very well not everybody who is in this space were aware of all that was enshrined under the Digital Health Act, including the Data Protection Act. So in realization of the UHC within our community, we have been trying as much as possible to build knowledge. Secondly, with the different partners, with the different human right holders, we have also been very critical and very passionate to build their knowledge. How best can we engage at the county, national, and at the global space? And also we've also been looking at how best do we also have a social mobilization aspect by engaging the duty bearers at that also that particular context, because also the government, the state person, they also need to understand. They may not be able to understand everything, and that's why we are having different partners here, so that this agenda is everybody's agenda, and we have to move with this agenda collectively.
Thank you, Adele.
So as Gift introduced me, I work with trustee known as Community Health Promotion Fund that is encompassed inside a learning institution known as North Coast Medical Training Center, where we are able to support students, especially the vulnerable students, to be able to pursue health-related causes. And I also sit in a network of young people in Kilifi known as Leadership for Impact. So I do not want to add, I think the other panelists have been able to give more strategies, but maybe just one that has become very key to us within Community Health Promotion Fund has been meaningful participation of the community. We've been able to empower our community around Kilifi to be able to speak out and take part in advocacy when it comes to maybe the strategies and interventions that the government is coming up with. And currently right now in Kilifi, we even have community action committees that take, or I would say they participate in the development of documents within Kilifi, and also the projects, and also even when it comes to maybe like funding of the dispensaries and the health facilities, we have committees that sit to be able to monitor and hold the county Department of Health accountable. The other strategy that we've deployed mostly when it comes to health advocacy is also lobbying. I think in the previous panel we had of how are we engaging MCAs. So we also faced a very big problem in the previous when it comes to advocacy, when we are working on advocacy in Kilifi County, because of now MCAs not being able to support some of the issues of that the community is trying to bring about when it comes to health priority areas. So for us, what we decided to do is we started lobbying MCAs and also policy makers, these are the CECs, to be able to come and sit down with community members, so that the community members can be able to share out the issues that they want, or the issues that they have within the community, so that when the MCA goes back to the county assembly, he or she is able now to be able to see the need of maybe putting up a budget, or maybe being able to pass maybe a bill within the county assembly. So thank you.
Well, thank you so much. For those who are yesterday, I introduced myself as Victor Karaoke, and I said I work with and for the community. And the community is people living with HIV and also people affected with HIV, because we normally say if you're not living with HIV, you're affected. And by affected, it's probably you know someone, and so and so and so. And one of the our main strategies, it's normally community engagement, and especially the young people. When you want to preach to young people, we normally go to their hubs. And if you wait to sit in a nyumba kumi, you will not find any young people. And how do we get them? We go to where their hotspots mainly. If there's a football tournament, if there's a basketball tournament, dance competition, and we normally organize such events annually. And we recently we had a concert called Dunda Yangu Bezi Yangu. It's where we were targeting to achieve the 90-90-90. So we went to the ground to get these young people, so we can make sure that if you're a young person and you do not know your status, you get tested, and you know, if you're positive, then you get started on treatment. If you're negative, then we get to educate you on how to live negatively. And other thing is we normally give grants, small grants to CBOs, majorly in places that are unable to reach. We have facilities in Nairobi, 3 of them. One is in Parklands, Mukuru, and Mathare. And Mathare, there is one place that just a regular guy with a suit ama nice sneakers hawezi fika pale, because one thing you get there, Akayanki will ask you, I like your shoes, so nipatie. And by that it means they are forcefully taking it from you, and if you don't, then so we work with CBOs when you washaji familiarize na sorry sana nimeshazoea kuwa na community Kiswahili imeingianga tu. So we work with CBOs that they familiarize themselves with those people in the community, and then at the end of the grant they come and give us our reports, and you know, we can see improvements. Yeah, those are some of the few strategies. Thank you.
Thank you so much. What stood out for me in these strategies that you have employed was meaningful participation, meaningful engagement, sensitization. It's very difficult to implement something that people do not know. So advocacy it shows that advocacy really plays a huge role even in this implementation of this digital health. So thank you so much.
And
yes.
you know, the previous WRC, the World Rally Championship, there was zile vitu za tuma na WhatsApp, that condoms had run out in Naivasha. That was part of our advocacy, because you know we also dispense condoms in places where you can find people who sex workers, men who have sex with men. So it was an advantage for us, because you know we got to take condoms there and have small groups and chats on, you know, encouraging guys, young people to get tested. Yeah, thanks.
Thank you. So thank you so much for that. So what would you say are some of the challenges that the fast surging technology poses on digital health?
Yeah, thank you so much. And one of the main one, and you know, as before the community, the panel that was moderated by Patricia, we talked about you know, ile data yako kupeanwa na you don't know what is being used, and one of the main threats it's cyber security and malware, and you know, I do not know my information itapata nani, and I do not want, if I'm seated and I'm in a discordant relationship, it's where one partner is positive and the other one is negative, of a sudden nimekaa chini tunaanza kuona pop-ups Instagram on where to get those self-test kits, or something that can indicate to my partner, and I'm not ready to disclose to my partner something that can indicate to my partner that you need to start looking in your partner. And then another thing is, so for our facility kuna the newly introduced KEMS, where all data yote ya people living with HIV is centralized in one server, where if I'm in Nairobi and I run out of my ARVs, I'm able to go to Kisumu and, you know, give that one unique identifying number, and the doctor is able to see the kind of regimen that I'm using and nini. So with that, then again kukakuja na something called ushauri. So for people living with HIV enrolled in CCC, there is this yellow card that is normally issued by NASCOP and the government of Ministry of Health. It's normally written up or something, and it can, if you see it, you can clearly see this somebody living with HIV. In case my partner sees it, they're able to see it, and young people don't like that. So right now ushauri has enabled it for young people to have that, all that information, the current viral load, the regimen they are on one platform. The app nimesema inaitwa Ushauri, it's both available on App Store and both on web. So this can be a challenge, because if kama even the young people will be accessing their treatment, there will be that loss of, you know, human interaction, because as a health professional ndakuwa tu nimekaa tu hosi na ngoja tu kudispense dawa kwa, you know, the next rider. We normally sometimes encourage guys, if you're not able to come for your monthly or after 3 months regimen, you can send somebody. So there'll be that, you know, loss of human touch.
Okay, so for the challenges, one, I would talk about myths and misconceptions. As Dr. said in the morning, you can imagine some of us came into this conference, we've left with a lot of information, meaning we didn't have a lot of information first on the laws that are around digital health and issues on also tech and innovation. So you can imagine, even within our communities right now, the small systems and even the health systems and even the record systems that we have in the hospital, still it's a very big challenge when it comes to information. And the worst part, whenever the community does not have information, it leads to a lot of myths and misconceptions. Like now, I want to talk about Kilifi because that's where I'm coming from. The moment that the community does not have information, for example, when we started the issues on COVID vaccination, you can imagine some of our community members were refusing to go for the vaccination because they kept on saying, "Hii ni story ya madevil worshipper." And you can imagine some of them went to an extent even to refuse, even for example, because as there's an issue of the Mwenye syndrome. When you talk of the Mwenye syndrome in Kilifi is you need to seek permission from your husband, especially for women, for you to access health services, even family planning. So you can imagine if they do not have proper information or the community does not have proper information, they now develop myths, and for the ones that know a bit, now they come up with a misconception because maybe something didn't work for that particular person or something didn't work for me, so I go back at home and start spreading the wrong information or start giving very wrong information. The other challenge would be religious and cultural beliefs. As I said, I come from Kilifi. This is where we were faced with issues of people not going to hospital because pastor amesema. So can imagine if still the community does not get proper information on some of the changes that we are having now on digital health, it will bring up more issues. You'll see even religious leaders now coming in as barriers or hindering now us being the community accessing services just because they don't understand or others feel this is something that is new, this is something that we've not been introduced to, and they now create norms or beliefs around that certain service. Then the other thing is generational inequality. So I've come, as I'm working with young people, I've come to realize within even young people, we also have generational problem or conflict. You can see that we have young people within the generation of the 1990s, and then now we have the young people around the 2000 babies. So you can imagine already it's in some ways we are differing even when it comes to in terms of languages. Now even when as we're working with them even in the youth-led spaces, if we are not able to come up with strategies or come up with ways in which you can be able to reach all the young people and feel that we own something, then already there's a challenge. Because even in some of the interventions we have right now, especially in Kilifi, every time we are asked, we have a lot of funding for to get rid of teenage pregnancy. Why is it not working? But I've come to realize some of the interventions we have are for young people at the age of Jackie's age. As we were helped with peer education, we were helped with sugar screening, we were helped with kulikuwa na ile video ya silent epidemic, ile unaonyeshwa the STIs. You see, such things helped us. But what of this generation that is coming up of the 2000? Are they going to be helped by peer education? And then again, we are assuming also they love phones and they are ready to take up information on TikTok. But again, have we asked them or we are assuming? Because now that's the other issue. We need to come up with strategies or we need to come up with interventions that are also generationally equal to everyone, that even the next generation that comes in, the babies who are going to be born in 2030, they also now need to be, they feel relevant within the digital space or the digital health advocacy that now we are bringing in.
Yes, thank you, Jackie. I'll talk of 3 challenges that is faced by the community that I represent. I work with the sexual and gender minority population. And if you look at the first surging technology that is coming up with so many applications, and also the legal framework, and also the community and the societal expectation, and also looking at the belief that individuals are also carrying with them at work, we've been having a lot of issues around queer digital culture. And when I talk of digital culture, I mean how the society has been brought up with different theories, with not correct practices of belief. We've had issues of how the margins the community are, and these have made the community to look very bad. And to an extent that when somebody stands with these people and they say there are men who have sex with men, and then people will like, but I've seen this on social media. If somebody stand and say, yes, I'm a trans person, I'm an intersex person, I'm a gender non-conforming, I'm a sex worker, I'm a person who uses drug, because all those particular components are under key population.
people have been modeled in a way they have that particular culture they believe in this particular community. The next one I see, Pauline, something. The next one is about the continuous bullying and bullying, extortion of the community. And most of the time you'll find that if somebody knows that you identify differently or you express yourself differently, and then they also understand from the context you're coming from, then they will always try as much as possible to make you feel inhuman, because they always feel like they have to disclose this to somebody else that is so dearly to you that when they report this, then you'll have to be in for it. And the last item that is coming with a lot of conversation under the trans organizing in this country is about the legal gender recognition, and we're looking at how best can we also get into to tap into this conversation, because we are having a lot of issues with the registration of the vital events. Because if for today a trans person will pass or maybe will die, then how will be the registration? And we are talking about the data protection, we are talking about the Data Protection Act and also the digital health. And this is a model that is going to gap a lot of digital divide. When we're speaking of geographical digital divide, we are talking about sexual digital divide, gender digital divide, the age digital divide, and all
the whole digital ecosystem, and it's very expensive to maintain it, and we're maintaining it via donor funds. So at what point is the donor going to probably get tired of funding this, yet a lot of young people really enjoy or rely on our hotline, or they rely on our website? All these things need maintenance. It's not like a one-off fee. The technology that goes into it, the back end and the front end. So I think the prioritization that a lot of the panelists have been talking about, we need to be able to prioritize this, and prioritizing it in terms of every aspect. So politically, budget, is there money actually being put aside for this, or we're just having a bill, or rather an act, we're making it because we want to look like, tukombele, because Kenya, I think we've constantly been getting a lot of accolades for having, some laws that are progressive and, being one of the first people to launch this and launch that. Donors or the Western world is always coming and launching things in Kenya. If it's not Kenya, it's South Africa, or both. So what exactly are we doing to make sure that we can keep the momentum going? And it's very sad that for some things we're seeing as if we're going backwards. So I think maybe we just need to come together as the community and make sure that everybody understands that we are all working towards the same goal. Because another panelist was talking about selfishness, and it really tickled me because it is there. So I think the prioritization and the reason as to why we're doing this, why we're even having this digital health conference, during this digital health week, is just to make sure that we are all going towards the goal. And the goal here we're seeing is the UHC 2030. So what exactly are we actually doing in our own capacities? Maybe you as an individual you cannot, but through the organization you can. I just think the reprioritization and prioritization of why we actually are here and why we need to work towards to make sure that everybody can be taken care of as we work towards universal health coverage.
Okay, so I'm told I have only 1 minute. So whereas the nexus between digital health and UHC has been extensively explored as the most sustainable way to achieving UHC in the country, it raises a problem whether in the future this will be yet another determinant of the quality of healthcare that we get. Will it be the same as whether you're poor or not, whether you're educated or not? In the next 5 years, we'll be talking about whether you have the digital literacy or not. And that will determine the level of your health outcomes in the society. So mitigation measures is to ensure that in the society they have the basic literacy levels which are needed to access these healthcare services, and also maybe we can have something like essential digital health. Those digital health services which serve the priority needs of our community in Kenya, whether it is infectious diseases, although that is changing. We need to look at what is our priorities in Kenya, and then we go to that direction to ensure that at least every person, they have something to hold on when it comes to digital health. Thank you.
Welcome. So our able MC, you stole our time, a lot of our time. So we have had to really try squeeze our discussion. So I'll allow all the panelists 30 seconds each to just give a parting shot. If you feel there's something burning that you've left out, maybe this is the opportunity. 30 seconds.
Okay, thank you. So I'll say that those of us who work in the community, we serve as the legitimate and should be the accurate voice of the community. We should represent what is in the community, what are the needs of the community when it comes to digital health, to ensure that we focus on the right direction.
Thank you for that. For me, I think it's just to make sure that as we are talking, it's very easy to be sitting here and talk about this is what needs to be done and this and that, but just to continuously not be tired of working or fighting the good fight, because I don't believe in this that people say that people have HIV fatigue. Watu wamechoka kusikia about HIV, yet we have people 15 to 24 who don't know how it is spread. So we need to continuously preach that the way we were preaching it when we were having all these people who are involved in this conversation. Thanks.
My parting shot is that I'm asking everybody to support what the PS for Ministry of Medical Services echoed about moving on with the conversation around community-led monitoring, because this is a strategy that will help us to hold accountability and also governance in health system. And another item is that there are so many people have been talking about collaborative development of this particular strategy. It is also very, very important, and I echo Kelly for ensuring that most of, if not all, but networks have been represented here, and we are also able to move that conversation with other organizations, and we see how best we're moving forward. And lastly, about evidence-based engagement, and that one I'm speaking about. After 1 year, can we just do a survey or maybe conduct a research to find out what are still the missing links, what are the areas of improvement, what is happening, are we achieving or not, how can we monitor and just do analysis of what is happening since the enrollment of this particular strategy.
Thank you, Adera. For me, my parting shot would be, we really need to invest on meaningful community engagement. And when I say meaningful community engagement, I mean, yes, we now have laws, we have documents. Please, can we go to the community? We need to get out of the boardrooms for the government, for all stakeholders, even for the CSOs. Let's get out of the boardrooms and let's go to the community. Let the community understand what is coming. For them to be able to take it and own it, they need to understand from the start what are we talking about when we talk about digital health, so that we can get rid of already the misconceptions that are already there, and even for the ones that are going to come. And I think the other thing, digital health is coming in to support us, make our work easier and to be able to deliver. So let it not make us go back to where we were, maybe for people to stop coming to the health facilities, for people to get to start giving birth within our homes. Let digital health come in to support and to bring efficiency and effectiveness.
Anyway, if you scroll in the streets of the interwebs, there's this fear that AI is coming to take our jobs and, you know, all that shenanigan. And if you can remember, maybe in the 2011 when Facebook came, people are saying that hii ni kitu Illuminati, inakuja ni devil worshippers. When COVID ilikuja, all the churches wanakuambia tuma msadaka hapo kwa Facebook, nini. You see, we all went digitally. So right now, let's not look at digital health as, you know, something that is, you know, an opportunity to sell your data or nini. It's something that will come and help us. So thank you so much.
Okay,
Tuwapigie makofi vizuri tafadhali. Give them another round, please. So we're going to take 2 questions. I'm seeing the yes. The online team. I've been wondering, we are more than 50 actually. But I'm only seeing 6 retweets on our pages. I'm disappointed. Please, let's make noise online. We are taking 2 questions, one arm. The first hand up. Yes, teenager. You would prefer to be called teenager. Perfect. We start with the mwalimu.
My question goes to Liverpool, the lady from Liverpool. Now, I'm a client at Liverpool, and we've been having a very, very good program for the young adolescents. There was a transition. After now, it became the Wema Clinic. And I've been interacting with most of them. So wherever they went, they were used to programs during the holidays where they used to have sessions, they interact, they share their challenges in schools, and then a follow-up would be done. So wherever they transited to, this is not happening. So you realize that most of them have dropped out and their adherence is very poor. As Liverpool, who initiated this to these children, what are you doing about them? Are you doing really a follow-up to wherever they went?
Thank you. Teenager, please make it in 30 seconds.
Okay, mine is to Adera. Adera, I think that sometimes back I asked about the LGBTQ community. I believe you have people with disability who are in this group, but they are hiding. They cannot even come out to talk because of stigmatization. Again, some of them, they are in LGBTQ community and they are HIV positive, and they are not coming out and communicating. What are the strategic plans which are there so we can reach them now that we have the Transform Health Kenya? How can they get this first-hand information to assist them?
Thank you very much. I would allow the panel to respond in, I think we have, the questions were directed to 2 people, LVCT and Adera. So we'll start with Adera. Go first.
Okay, thank you so much for that question. I think the other time, let me tell you, even the government itself is doing a very good work. For us even to have the community health promoter chapters is even a plus to our organizing, including the community health volunteers and the workers that the county has, plus our own peer champions, our own peer educators. Remember when I started, I said building knowledge and empowering right holders. And this is something that we are very passionate about, because we are looking at how best do we also make the legal framework and the policy that is very inclusive to everybody, so that everybody can get these particular services in a very quality manner. And you're asking how best do we also reach out to the disabled, sexual and gender minority population, and also people who are also living with HIV. There are quite a number that we're already working with, but we still continue with the conversations with even the community liaison persons, because not all these people, we may have them under the community or under the organization institution for the services, but we are also extending and just putting the best foot forward in the larger society, so that everybody, by a click, you are able to pick, and being sensitive, and also ensuring that this particular population, these are their needs, these are what they suffer, and also this is how to walk the journey with everybody in the society. So we are very categorical in engaging with the community promoters, the community volunteers, peer champions and peer educators, including people who are working across the subscription of human rights.
Thank you for your question. It brings me back to what my parting shot was, the expenses. Now, unfortunately for the, as you mentioned with the transition, those some of those young people were transitioned into other facilities. So it is the responsibility of those facilities or organizations, because it was a mix of both, to make sure that they're following up with these young people. And even for part of the transition, it was because of funding. Yeah, so there are a lot of people who stayed with us and stayed within the Wema Clinic, but those who are not able to continue because now there was a cost implication that was added on top of that, there are others who were transitioned into other partners and into other government facilities. So unfortunately, if they're not employing what usually used to work, especially with the community engagement, because I know for a fact the ALHIV that we have really enjoy and look forward to those, they're the ones who even come up with their own ideas to do that. And it's sad to hear that they are now falling off the wagon because they don't have the proper support that they need. But it's great that you've even asked that, so that for those who are partners here who have access to these young people, the adolescents living with HIV, to support them, because as I mentioned before, the needs that they have are very different compared to an adult or an older person who's living with HIV.
Thank you very much.
So I just wanted to maybe assist with then the question that Mwalimu has asked. So for us in Kilifi County, because LFCT is also working in Kilifi County, what we've done for, to support the adolescent to transit is through the Youth Advisory Council. What we did, we advocated for the county to now take up the program. So what has happened is within the health facilities that the young people are, the Advisory Council has a budget line within the county. That is what we did. So the county, every time they come up with a budget, they must make sure that within the Department of Health, they have a budget line for the Youth Advisory Council, where now those adolescents are able to be supported within the program.
Thank you very much. So we have some questions online. Most of them are comments, so great discussion. Thank you so much. We have community ethically involving young people in digital health reforms will help them trickle down to their peers. Jacqueline, categorizing the youth in their ages is a great initiative. Thank you so much. Let's not forget youth and the right holders in the discussion. Okay, displaced. Okay, I like the submission on digital literacy. Please join them for a photo. Where the cameraman, please let's give them a round of applause. As the potato exit, you'll join them for a photo. Thank you. Another round, please, for them. Thank you very much. Let me hold that through. Please smile. It's a beautiful afternoon. Thank you. Tuwapigie makofi wakiondoka tafadhali. Tuwapigie makofi tena. Thank you for great insights, great discussion. We really appreciate. So as I was saying, please, let's continue with this conversation. You can see that we have a lot to discuss, and time is always against us, or it's us against time. I don't want to say it's us against time, because time is it's us against time, right? Yeah, so please let's continue with this conversation. Let's engage on our social media handles. We know all the actually, to my shock, I've only seen, I think we need to give Timothy a round of applause, because he's the only one who has been tweeting, to be very honest. If we've been monitoring carefully, he's the only one tweeting, and very few. And the Strathmore School, thank you for joining the conversation. I noticed you just joined a few. I don't know their name. Please tag Transform Health, tag all the organizations that I had mentioned so that we can see the feed. Sawa. Are we together? Okay, as we prepare to get to the next presentation, allow me to recognize the presence of Dr. Wasuna. Thank you so much for joining us. He was here with us yesterday. And Dr. Joyce, we are pleased to have you. Thank you so much for joining us. We're changing gears, getting to gear number 4. Please tighten up your belts, because it's now about to take off. All right. So allow me to welcome. Are you ready? Okay. The next discussion, it's a presentation by Polly, and the presentation will be about the future of healthcare in digital health. We heard from Dr. Sittenei that government is always futuristic, always planning ahead. So we want to see what does that future look like in terms of digital health. So the recommendations from the research on digital health and human rights of young adults in Kenya. And then we also have, so joining her for the presentation thereafter would be Angela Sitei, Director Health Innovations, Farm Access. Please get your presentations ready. Get your presentations ready because now, yes, 15 minutes started 2 minutes ago. So you have about 12.5 minutes to do this. Karibu sana.
I had a So as Trevor is preparing the PowerPoint presentation, I am just giving a disclaimer about what I'm about to present. We have had so many discussions today on different aspects of digital health, and a majority of the content I have to present to you today has been touched on by different panel discussions and also by different presenters. So I have a confession to make, but before I make my confession, I want you to confess 3 things to me. So by a show of hands, how many of you click on the terms and conditions button on websites and apps before you accept? By a show of hands. No, the question is very direct. So it's a yes or a no. So if you click on the terms and conditions button to at least open, okay. Now, how many of you read the terms and conditions? I'm seeing at least we have 1 or 2 people in the crowd. Then how many of you know how that data is, the data that you give is used or processed? So here's my confession. Neither do I. 80% of the time, 80% of the time, I do not read the terms and conditions. I try, so maybe I'm just in that 20%, but I do not. So today, we're going to talk about, yeah, it's okay. So today we're going to talk about something that affects us all. We will look at the UN Special Rapporteur report on digital technologies and the right to health, as well as a research on digital technologies and the right to health, where Kellen collaborated with global organizations, including Stop AIDS and GNP+, to mobilize young people and vulnerable communities to provide input to that report, as well as a research conducted by Kellen on digital health and human rights of young people in Kenya. So the UN Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of mental and physical health, Dr. Talgen, analyzes the impact of digital innovations and technologies and the right to health, including accessibility, availability, accountability, and quality of facilities, goods, and services provided in health. So here are some of the highlights that are given in the report as well as the research. So the first one is on availability, accessibility, acceptability, and quality of health, facilities, goods, and services. So digital innovation has improved access to health facilities, goods, and services by providing new tools for diagnosis, treatment, and prevention. For example, telemedicine allows doctors to remotely diagnose and treat patients who live in remote and underserved areas. Digital technologies have been used extensively to manage the health needs, a good example being during the COVID pandemic, where the state could quickly educate the public about the virus, assist with symptom recognition and reporting, which also one of them being contact tracing, where if you went to get a test, they could when you have noted someone, they follow up with them. So similarly, mobile apps can provide information about health conditions and treatments, as well as reminders to take medication and and to attend and book appointments. Another digital health innovation that has gained traction in Africa, and we also saw it in the previous presentation, is the use of electronic health records. By digitalizing patient health data, healthcare providers can more easily track patient progress, identify trends, and make more informed decisions about treatment options. This has the potential to improve patient outcomes and reduce healthcare costs, looking at insurance companies in the room. We therefore have to look at accessibility within the 4 dimensions of non-discrimination, physical accessibility, economic accessibility, and information availability. Secondly, we look at the right to privacy. By significantly expanding the quantity and the quality of the data that is being gathered by digital platforms and also technologies, we can explore new potential uses of health data, including big data, to promote the fulfillment of the right to health. Some of the options that are available to us, we have not yet even looked into them. So health information is some of the most sensitive personal information there is, and it should be treated with the utmost care. Digital technologies can help us manage our health information more effectively, but they also pose a significant risk to our privacy. For example, health apps that collect data on our sleeping habits and exercise routines may seem unconscious, but information can be used against us by insurance companies or our employers. Sometimes you might not know, we do not know how our health data is being used. Insufficient protections for digital health data can leave marginalized groups, who are vulnerable to criminalization, stigma, and discrimination and violence, susceptible to those things. In certain circumstances, and depending on the legal framework in place, some companies, and even the public sector, can be compelled by law enforcement bodies or courts to hand over personal data for criminal investigations. And this was actually seen when we had, I think they passed a law that opens up some of the government to be able to look at some of your information for money laundering provisions. So these risks can sometimes also spill over to health. It is crucial that we are aware of these risks and we take steps towards protecting privacy. The third aspect is looking at sexual reproductive health. So by a show of hands, how many of you have Googled your symptoms before? Be honest. If you've ever Googled your symptoms, did you think you were dying? So many young people in Kenya lack access to comprehensive sexual education and healthcare services. Digital technologies can bridge this gap by providing information and resources that are otherwise inaccessible. For example, mobile apps can provide information on contraceptive methods and STI prevention, while telemedicine services can actually connect young people with healthcare providers who are remotely, and also improve access to safe and legal abortions. So online communities and support groups can provide a safe space for young people to discuss sensitive topics and seek advice without fear of judgment or shame. By leveraging the power of digital technologies, we can empower young people in Kenya to take control of their sexual reproductive health and make informed decisions about their bodies. We, however, have to be cognizant of the fact that intrusive data collection, such as gathering menstrual information from those apps that we use, tracking trends of purchase of pregnancy kits, because now we can actually be able to get our drugs online, and fertility tracking or contraceptive methods have the potential to be done without consent and sharing such personal data by profit-seeking parties, which could expose people to harassment, intimidation, and violence, and also exploitative profit-making schemes. I will skip AI. and then go, because we had a discussion about AI, and that is a whole discussion, so we can have that, and my time is short, and go straight into access to information. So with the increasing use of digital technologies, access to information has become easier than ever before. However, not all information available online is trustworthy. It is therefore important to provide people with reliable sources of information, such as government websites and reputable organizations like the World Health Organization website. So then we now look at what were the recommendations that came from both the UN Special Rapporteur report as well as the research that was done by Kellen. Excuse me. I have grouped these recommendations into 5. And the first one is on stakeholder engagement. So looking at the presentations that were made yesterday and today, the future of digital health is literally within our grasp. It holds the potential to transform the way we experience healthcare. To shape this future, I now present to you these recommendations. Number 1, we need to have comprehensive stakeholder engagement. So let us embark on a journey that involves everyone. The healthcare providers, financing specialists, I love the discussions that happened around financing of this sector, policy makers, tech, and also insurance firms, and even to the individual level. By investing in data literacy, systems, tools, and protections around that, we can ensure that digital health benefits us all. We also look at the technology's role in empowering access to information. Recognizing the role of technology and social media, the second one. So recognizing the role of social media companies is essential. We must uphold the right to information while protecting marginalized groups, marginalized groups and young people through well-considered policy frameworks. We also have to look at equity in digital access. We need to embrace digital technologies to enhance healthcare access for marginalized individuals, but we have to do it the right way. Implement human rights safeguards to prevent any deepening of inequalities that are currently existing. We also have to look at balancing innovation and responsibility. I know we're all after money, and money makes the world go round, but we have to balance both of this. So as we drive into the world of digital innovation, let's maintain a vigilant eye at both the positive and negative aspects to ensure that the right to health is for everyone. We also have to ensure that online safety is considered. It's time we address surveillance and safety issues in the online spaces. It's time we address surveillance and safety issues on online spaces, guaranteeing visibility and protections of all communities, including the LGBTQ communities. We also have to look at bias mitigation when it comes to AI, and this was talked about yesterday. We cannot overlook the bias in coding and AI tools. Our commitment to data transparency and inclusivity demands that we rectify these biases and put in place systems that mitigate risks that arise from this, so that marginalized groups are not rendered invisible. We also have to look at a user-centric regulation. We also have to look at user-centric regulations. So let's create a regulatory environment that actively involves users and subjects of digital technologies, emphasizing transparency, explainability, and accountability. We also have to look at global data protection. The thing about going digital is the fact that it draws a blurry line between countries. We have social media platforms whose headquarters are not based in Kenya. What happens if you're seeking justice and you cannot resort to justice within a court system in Kenya? So we need to ensure that we implement robust global, regional, and national regulations for personal health data. This is crucial for the inclusive and participatory digital health governance of not just Kenya but other countries, because if you have to transfer your data to another country, you want to ensure that it is safe. This now also goes into the conversation of transnational accountability. So as a country, we should be involved in the development of a transnational code at that global level to regulate private ownership, private ownership of data, data extraction and data banks, which this will hold technology companies and states accountable beyond our national borders. We also have to ensure that looking at health, it is not just a one sector approach. It is incorporated with finance, with human resource, and so many other aspects so many other departments that I cannot finish to list. So we have to engage a multidisciplinary and multi-sectorial process to inform policymakers and allocate resources effectively. We also have to look at multi-sectional collaboration. We have to engage, I think we've talked about, then we also have to look at public investment and trust building. I think this is my second last or third last slide. We have to ensure that public investment in national networks, coverage and connectivity, and build trust from the bottom-up approach, and ensure that there is community engagement in the advancement of digital health. We have to also ensure that we do impact assessment and participation of everyone when it comes to health programs. Once processes have been designed and we're thinking about implementing them, we have to ensure that we actually do a check to see what is going to be the impact of some of these things that we're trying to introduce. And I'm hinting at the digital superhighway that is coming in. And my last recommendation is on ensuring that we have that human rights principles are incorporated into all this. Always remember that at the core of human rights principles is equality, non-discrimination, participation, transparency, and accountability. These must be the foundation of our digital health journey. So then, in conclusion, I want you to take a minute. Picture a world where digital health doesn't just promise progress, but actively engages stakeholders and protects the vulnerable groups and empowers all the marginalized groups. Let's explore a roadmap to the future of digital health that revolutionizes the way we care for one another. We have to ensure that as we do this, we take into account inclusivity, transparency, and human rights for all. Thank you. That was my presentation.
Thank you very much. Thank you. She managed to do it in 13 minutes. Wonderful. Thank you again, Pauline. Human rights approach to health service delivery. So should you forget everything else, please remember that, okay? And I know this, the presentation is available. I know we didn't have time to delve deeper into it. So, and I know Pauline is willing to share it with everyone else. So please feel comfortable that this presentation will be shared with you. Tumpigie makofi tena. Allow me to call on stage Angela. City Director Health Innovations Farm Access. Tumpigie makofi akikuja. Let's give her another round. Thank you. Trevor, please. You're open to access with.
afternoon. My name again is Angela Sitei. I work at Farm Access. I'm sure for some of you who are here yesterday, you may have heard a bit about Farm Access from Dr. Asuna. I work leading the arm that seeks to generate evidence that the use of digital technologies to address these issues that we are talking about is actually possible. I lead a team that is under the arm known as the Health Innovations. And this is where we actually look at the ecosystem and look at it from the lenses of the stakeholders. Somebody talked about using a human-centered approach. So really looking at that, engaging all the players in the ecosystem and looking at what is the problem and whose problem is it. Before then we can design solutions together with partners to address those problems as a way of demonstrating the untapped possibilities of the digital technologies. Today I'd like to share with you on how we can actually transform NCD care for patients in Kenya and the role of digital innovations in remote care monitoring, with a focus of diabetes and hypertension. I'll be going through who we are very lightly because I think Dr. Asuna went through us in depth yesterday. Why non-communicable diseases? Our hypothesis before we designed the program. How we did it? The impact and evaluation results, because we actually worked with APHRC, Africa Population Health Research Center, to evaluate the impact of this program. And so I have the results there. And based on the learnings that we got, the outlook that we have. Before I start, I think my colleague who came before me asked about, asked a question. I'd like to ask a question actually immediately after this. So Farm Access, who are we really? We are an NGO, first of all. We have offices in 4 countries, Tanzania and Kenya, Ghana and Nigeria, but we have footprints across Africa, Asia and Europe. At the heart of what we do, basically we exist to innovate to make the health markets work. Looking at the lenses of from the lens of both the supply and demand. Our vision actually is that the impossible is possible because we care. Those lenses, therefore, is that at the heart of what we do is actually digital innovations. We have solutions such as the ones that were presented today by my colleague Kennedy, called the Medical Credit Fund. We actually provide loans to health SMEs in partnership with local banks. We have solutions such as SafeCare, which is a quality methodology. You may have seen it, SafeCare brand with different hospitals. That is a methodology actually that takes hospitals through a stepwise approach towards improving in quality. We work with counties to support states in realizing UHC using mobile technology. We are with Kisumu trying to support them in realizing, identifying the indigents through MTIBA as a partner, but also looking at the informal sector and how we can, generate local financing, pool funds locally to be able to support UHC. With all that, then we actually do generate evidence through research and analysis where we can advocate, have advocacy that is evidence-based. At the heart of what we do is actually technology. Back to my question. I presented the same last week in Nigeria, not Nigeria, but Tanzania, and I asked the same question. How many of you either know somebody who has a non-communicable diseases? In Tanzania, they call it magonjwa yasiyo ambukizana. That's the new word I learned. Or actually have it. Raise your hand. You know someone or you have it? The ones whose hands are not up, you actually do not know anyone who has either hypertension, diabetes, cancer, or all those. So NCDs actually, someone actually mentioned about human rights. It's a human rights issue. NCDs account for 45 million deaths across the world. 70% of these are actually in the low middle income countries. We fall in that 70% bracket. And that's why most of our hands are up, if you realize. It's a human rights issue. In Kenya, NCDs will soon be the leading cause of death. If you realize, insurance is actually either minimally or not covering for people who have hypertension, diabetes, and other NCDs, cancers and the likes. Or if they are covering your register, you have to have a waiting period of at least 2 months before you can access. For the ones who are registered on NHIF, you realize that majority do not contribute, because if I contribute, then I actually don't go, and if I go to the hospitals, I don't get my medication. So NCDs are actually already dominating the healthcare budgets in Kenya. At the bottom of NCDs in Kenyan adults is as follows. 50% actually of us suffer from pre-hypertension. 25% are hypertensive already. 5.1% have diabetes, and 20% are obese. From the population from our population, less than 10% of patients are either on treatment or controlled. There's less than 30% that are on treatment but not controlled. Another 50% that are aware but not really on treatment, and the other half are actually not aware. So our hypothesis when we were starting this program is that patients can actually take charge of their own health. In Western countries, patient involvement in healthcare models from, digital remote care and all that has shown effectiveness, but there's limited information or research, or very little is known about the low middle income countries. And so we sought to actually create evidence. The current healthcare systems is really overburdened. The incidences of NCDs are really high. When you go to the hospitals, the doctors are really not able to take care of these numbers, either because they are few, we were told about the specialist numbers yesterday, or that the supplies are not there, commodities are not there, where we said only less than 10% are actually diagnosed and on treatment. In Kenya, research has also shown that the effects of adherence through, behavior motivation such as peer support groups, meetings and reminders actually work. So we sought to seek, we wanted to address this question. Can patients in Kenya take charge of their own health? Therefore we designed a digital model, care model. We developed it with the following hypotheses tested, right? The first one is digital tools can enable access to care. The second being digital home-based monitoring improves patient involvement and health status, and that peer support groups actually and text reminders have a positive effect on health outcomes. When you look at these photos, 2 photos, the first one is a traditional way of healthcare. You have to go to the facility, the brick and mortar. But this other one is a blended care that has been demonstrated across Europe, but the one that many of us, I think some of our tech innovators are also trying to demonstrate. So what we did, in November 2018, we launched this program through support from some of our partners, and we piloted in 12 healthcare providers in Nairobi, Nyeri, Kiambu, Vihiga, where 1,600 the program, we took baseline data of their baseline data. They were registered on MTIBA, where they were able to start saving for their healthcare, because we piloted this with private facilities. So they were able to save on MTIBA, but we are also able to subsidize care through MTIBA. For those who may not know about MTIBA, MTIBA is actually a mobile platform where the patient that connects patients, care providers, and the payers. And so as a patient, and I can actually put my funds there that is locked for healthcare, and I can use it for healthcare only. but we'll be hearing more about MTIBA from Peter here in the coming sessions. The same patients, therefore, were able to get another app. They were able to do, where they were able to receive coaching on healthy behavior via the mobile application. They would get messages. We would send them messages on, yesterday Dr. Sitiene was telling us that an informed patient is an empowered patient. So they would be told about, eat this, do not do that, exercise. So the do's and don'ts, really to keep them informed on how to manage their conditions. So they would receive coaching on a daily basis through this phone. They would also, the patients we connected them through the patient support group. At the time, the support group was not as vibrant as now. Support groups are not as vibrant as now, so we connected them to patient support groups, signed them up, and supported them out even to register through the Ministry of Social Services. So they were recognized, actually a recognized group. At the group level, they would again continue the education. They would mostly meet at the hospital, so they'd collaborate a lot with the doctors. Clinicians will use the opportunity to teach them on how to care for themselves, to teach them how to do measurements, but also to just connect with their patients. These patients were also were enabled to self-monitor. We taught them how to measure their BP readings and also their sugar readings. We were able to facilitate glucometers and BP machines. When they measured, and with these devices, they were actually able to measure at home, especially when we blasted the message for them, reminding them to measure. They were able to measure at home, and they were able to send their readings through the phone. On sending their readings, if the reading was high, the app would actually alert the patients when the values were out of range and would tell you, measure again. And if they confirmed high, it actually would prompt you to go to the doctor. At the doctor, was actually informed on the health status of the patients, and they were able to do teleconsultation. So at the back end, we were able to connect the patient's data from measurement at home, but also the clinical data as they were being seen by the doctor. The patient could actually visit the hospital at discounted prices. So if you realize, we were actually able to identify the gaps and eliminate those gaps. The digital tools that we use, therefore, from the patient side is the app and MTIBA. And on the side of the hospital, we were able to provide them decision support tools that they'd be able to track their patients even when they are not at the hospital. So a doctor would actually say, out of 100 patients that I have, maybe 50% are not controlled. So-and-so has other risk factors. Let me prioritize. I can actually see that their readings are high. Let me prioritize them to come to the hospital. That way, what would happen therefore, previously patients would tell us that I would come to the hospital when I'm unconscious. I'm being told I have 5 minutes. I'll try my best. They'd say, I used to come to this hospital when I'm very unconscious, but now I've actually stayed 3 months very much controlled, and I've not had to be rushed to the hospital. Because, through these digital tools, the missed opportunities were averted. If my readings went high, then the doctor would be able to see that. The model, therefore, was able to decrease cost, improve outcome, and unburden the health system. The patient was empowered with access to care. They would be able to self-manage at home. They'd be able to access, care at discounted prices through MTIBA, because we had negotiated the cost also at the hospitals. But they're able to, get supported through the platform and behavioral coaching, but they'd also get immediate feedback on their health status. The healthcare provider as well had, reduced burden of healthcare staff to improve quality, because now patients who are not controlled are the ones who are prioritized to come to the hospital. And then there was transparency on the payer side also on how the cost, the money that was given was utilized. They would get, insights on outcomes, but also on the financing. So these are the results that we got on the care model as far as adherence to care, that actually patients were able to adhere. What is documented currently is that in literature is that adherence is usually at 25%. With this program, we were able to demonstrate adherence at 46%. Both BP and blood sugar levels moved to healthier values from the onset of the program because we were able to continuously engage and inform and empower these patients. About 80% of all costs from our data, was spent on medication, and 70% of all these care costs were spent. 34% of these patients who had both conditions. Actually, most of the cost was taken up by those people who had both of the conditions. So it's really demonstrated that care outcomes are better. We also saw that, the care improved, but those who are in patient support groups were able to get better outcomes than those who did not participate. If you realize, they measured more, but also improvements came, both from the BP and sugar readings. Part of this evaluation is that we would send, we sampled out the groups and were able to send, behavioral nudges on a weekly basis, on a daily basis, and on a monthly basis. We realized that those who measured the most, half of them actually are the ones who did measurements on a monthly basis, and that blood pressure and blood glucose and and consumption of unhealthy foods reduced, especially for those who are part of the in a support group. This is my second last slide, I think. So what are we doing now? We have demonstrated that it's possible actually with technology to be able to improve efficiencies, but also bring down, improve outcomes. So we are building on these learnings of phase 1, where we are taking these models through the innovation funnel. Again, taking it and looking at, okay, it looks like patient support groups are actually working, and remote monitoring is actually working. Technology can be used to do this. So now we have collaborated with Nairobi County and are looking at this with these two lenses of support groups and remote care monitoring. And remember, this is for the minority, and have taken it through the discovery phase again. This is the innovation funnel. You go through discovery, problem, solution, fit, all the way to where you're taking the product to the market. To really understand, is there a problem worth solving here? And what is the scope of this problem, and whose problem is it, so that we can address the problem. We are looking at building on the learnings to develop a blended care model to demonstrate the untapped potentials of the digital technologies in line with, this is my last slide by the way, in line with the Kenya digitization agenda. So we look at ourselves as that sandbox or that lab with all these conversations that we've had yesterday and today, digitization, standardization, and we're looking at, for NCDs for instance, how would this look like? We believe that we can actually be able to demonstrate that we can bring, we can analyze this ecosystem and look at the gaps and bring in all those stakeholders that actually can offer solutions. And in that sense, I think we'll be reaching out to some of you. Based on our analysis, we can actually say, maybe we need an SMS service for this to plug in. Maybe we need a financing mechanism to plug this. And the whole idea is that leveraging on the national framework for establishment of NCD care, but also the two Bibles that we are told yesterday, that we can actually demonstrate that, it is possible to digitize and have shareable health data for chronic diseases. Thank you.
Thank you very much. Tumpigie makofi tafadhali. Thanks so much, Angela. But in short, it's possible to digitize and share health information for non-communicable diseases. Ni kweli? Yes, thank you so much. Tumpigie makofi tena. It's afternoon, I know, and it's in the habit of adults that at this moment we start thinking with our eyes closed. So I would request all of us to be upstanding. Please stretch. I know it's a bit cold, so shake your body so that you can gain some heat. Okay? I don't know whether you want to play us something. Just stretch. And I've been informed that just a few hours ago, two goats decided to lose their lives for the sake of this group here. Mbuzi wawili decided to lose their lives for the sake of us. Is it that beautiful? So we are all requested to stay behind for the gala dinner that would be happening after the closing ceremony. Okay? And I'm told that Kelin gave all the monies to the branding companies in Nairobi, and they have branded for us beautiful gifts for everyone. So please don't leave. Okay? So if you go to one bottle of please log into your Mentimeter. It's coming up. And send in all your questions regarding the two presentations, one that was made by Pauline and the other one by Angela. Please send in all your questions. Team, the floor is all yours. There is the code 510726. Please send in your questions. The first presentation was on the future of healthcare in digital age. If you had questions for that particular presentation, this is your time. And the second one was on the recommendation of the innovation technologies and the NCDs, the one that was shared by Angela. If you have a question, please post it there. Take it away, sir. And your 30 minutes starts now. Thank you.
My 30 minutes. Bado. As my panelists are preparing to join me, my 30 minutes are not yet starting. But yeah, thank you for the introductions, and thank you all for the energy in the room. Timothy Wafula from Kelin, and I will be moderating the next panel conversation. I know it's been a 2-day of intense, deep reflections, deep recommendations and on digital health and digital health technologies to achieve UHC. As we come almost to the end of the conference, we still have one session that I will moderate for the day, and I'm still waiting for one of the panelists to join. That's the reason why my panelist is here. And just want also to confirm whether maybe Eric Angula is in the room. If not, I've not seen him. Okay, thank you. Thank you. So I have all the panelists. Now I can introduce the session. So thank you. As we almost come to the close of the conference, this is the session 10. So we've had almost over 9 wonderful sessions, intense conversations from different speakers. So with this particular panel, it's a panel that we want to have a quick reflection around the using digital innovations to unlock more value in healthcare. And on my panel, I will allow them to introduce themselves, but just quickly to mention that we are joined on stage by Dr. Kanyenje Gakombe, who is the chair. Please clap for Dr. Hari, who is the chair of the Kenya Health Care Federation and CEO Metropolitan Hospital. I'm sure Dr. Hari will also introduce himself and give us more around what he does. We're also joined on stage by Peter Piaket. I hope I'm not mispronouncing your name, but please give it to Peter. He is the managing director of MTBAM, and we are also joined on stage by Pamela Dhiambo. Appreciate Pamela from the Reproductive Health Network of Kenya. And as I start this conversation, I will want to start mostly with Peter. around who leads one of the major solutions in the country. So I just wanted to, we just want to hear from you. Maybe if you could quickly just share the experience that MTIBA is using to unlock more value in healthcare, and you can just share a little bit around what do you think, or just your perspectives around how MTIBA is actually adding this value, and maybe any recommendations that you can give from the experience that you've been leading MTIBA platform in Kenya for quite a while. So you can start, I think maybe it's just by introducing to us to the platform, then let us know how it's actually leading to unlocking more value in healthcare, and any recommendations now as we move towards now the UHC agenda in the country. Peter, the floor is yours.
Thank you very much, and thanks for the kind introduction, dear MC. So happy to do that, and good to see you all. Thank you for the stamina, staying around for the last session, number 10. It's great. So we're all proud of you. So let me try to also keep it light. So maybe just good to first of all, by the way, you pronounce my name well. It's Peter, just like the Kenyan Peter. There's an I in my first name which throws everyone off, but it's indeed the Kenyan Peter. So so at MTIBA, for those who may be familiar or may not be familiar what MTIBA does or what MTIBA is, but MTIBA is actually a digital payments platform specifically for healthcare expenditure. And we have many applications, many ways or forms. In several of the, Angela already mentioned us in one of the programs where we were featuring as a savings wallet, so people can put money aside in the MTIBA wallet, just like you put money in your M-Pesa wallet. You can also put money in your MTIBA wallet, but the difference is that it can only be used for healthcare. So if I'm stuck at the facility, if I'm stuck at the Metropolitan Hospital, and I call my brother and I say, I'm stuck, I want to pay the bill, it was affordable today, but still I need your help. If my brother would send money to my M-Pesa wallet, he's never sure if I will really use it to pay Dr. Kankome's bill. But if he sends it into my MTIBA wallet, he's for sure, assured that I can use it for healthcare only. So that is our original approach. But a couple of years ago, we pivoted towards administration of insurance products, so health insurance products, because we do believe that for us to all be financially resilient and for MTIBA to deliver on our mission to make sure that all of us Kenyans are financially resilient in healthcare, we do believe that we need to move into this concept of risk pooling. So where everyone chips in a little bit, and then when one of us falls sick, God forbid, then actually our insurance product can help us. And we realized that actually our platform was very following the same kind of journey as that insurance products do. So we started to work together with insurance companies to provide digital platform services for them to administer their claims, and then to also help them pay the hospitals in a timely and efficient manner. And recently we've started to also provide those administration services on behalf of insurance companies. So we're not only providing the digital platform, but actually doing the claims assessment, the payments towards the hospitals, and even the customer experience on behalf of the insurance companies behind the scenes. And that all, to contribute to our mission of making health insurance more easy and affordable, because that's what we like to, work on at MTIBA, is to make sure that health insurance is easy and affordable. For those who are familiar or enjoy insurance products, it's actually, almost need a PhD to understand an insurance policy in terms of, the limits, the sub-limits, the exclusions, the waiting periods. It's one of the remarkable industries, I think, and sorry if I offend any insurance people here, but it's one of the remarkable industries who've completely optimized the products for themselves and not for the client. Because normally companies make products for their clients because they want their clients to buy, but in insurance, it's an exceptional situation that typically the person who buys the insurance is not the person who enjoys the product. The people who buy the insurance are the HR managers of companies. The retail market of insurance doesn't really exist in Kenya. And even, to be honest, in where I'm originally from the Netherlands, there is a retail market for insurance, but the only reason why people buy it is because the government has made it mandatory. There's no one who wakes up in the morning and thinks like, oh, let me feel good, let me buy from my new salary an insurance policy. People are typically buying something that they can, touch, can relate with, see immediate benefit from, and that's typically not the case with insurance. So what we try to do as MTBA is to really play our part in making sure that those kind of products become easy and affordable. As I said, through the digital platform, but also through administration services. And Timothy, you're asking me, like, maybe you can highlight a few practical, tangible ways in the way we do that. And I've sort of listed maybe 2 or 3 things. So number 1 is to try to make it more transparent and intuitive for the end user. And we do that through our mobile connection. So MTBA sounds a lot like M-Pesa. That's because we're family with M-Pesa, but also because our MTBA journey follows the same steps. So whenever you use your MTBA wallet, you get an SMS just like you get an M-Pesa SMS whenever something has been used in your M-Pesa wallet. So we try to make sure that our users can access their wallet or their insurance benefit on the mobile phone through USSD or the app, and have insights in how much balance do they still have, when is it being used, are my dependents there. So what we want to make sure is that people are not surprised when we show up at the hospital, when the cashier tells us, like, sorry Peter, your balance is out, you actually need to pay out of pocket. Or sorry, your child is not yet added on the policy, let us call the insurance company first, so please wait there for an hour or 2. So we want to make sure that is, that we're ahead of the curve, so that we empower our members to actually be in control and in charge and really enjoy their insurance benefits, which hopefully results also in a bigger uptake, because if people have a good experience with it, then they like to buy and afford it and protect themselves with it. So I think that's one angle, so trying to create that transparency towards the end user. The second angle is, I think, that we would like to pursue administration, we like to make an administration more efficient. And now I will actually unleash a whole lot of buzzwords, because our digital platform uses AI, big data, analytics, etc., to make sure that claims adjudication becomes faster and more automated and more efficient. Because hospitals are kind enough to enter detailed claim information on the MTBA portal, either through our portal directly or through integrations with the HMIS systems of the hospitals. And as a result of that, insurance companies now, immediately after the visit, have full insight in what was claimed on the insurance benefit on a very granular line item, including diagnosis. And that means that we can automate some of the adjudication of claims. And it also can make sure that we can pay Dr. Kakoma much faster, that Metropolitan doesn't have to wait for AR to put up stacks of paper and look at it for a couple of months and then finally try to transfer money. So we want to make sure that we can do that much faster and efficient. And we've seen tangible impact there, where turnaround times are slashed from a couple of months to a couple of days. So we want to make sure that we play our part in that. And that is very necessary. So you may think, why is that necessary? Is it necessary to make insurance companies even more profitable so that they can build another tower in Upper Hill? No, it's necessary because we need more affordable insurance products. A traditional insurance product costs an arm and a leg, and that should not be needed. That should be that we should have a full range of offerings of cheaper insurance products. But that is only possible when you make the cost of administration low enough for people to can do it profitably. So that's why that is relevant. And last but not least, I think we're also trying to do our part to lower the healthcare costs, because the reason, actually something very counterintuitive happens. Typically insurance prices in hospitals are higher than cash paying prices, which makes sense but also really does not make sense, because you would argue that insurance companies aggregate demand so that they could negotiate better rates or out fraud. There's a lot of fraud, fraud from members who misuse their policies. Every day we see the data, and you cannot hide behind the data. We see people who show up on our dashboards, anonymized, GDPR compliant, but they show up because they have used one single prescription in 18 facilities within 30 days. So they basically go and shop and get medication and stock their own pharmacy. So those kind of things happen, and it's partially it's funny, but partially it's also sad, because in the end, it means that just an insurance product becomes more expensive, and it excludes people who would otherwise be able to afford it. So, those were some of the examples I wanted to highlight in how we try to contribute to that mission.
Thank you, Peter. I think you've really delved into the value addition that you provide, and I'm sure I'll come back to you as for maybe a follow-up question. But I'll want to now move to Dr. Gakombe, and you wear two hats, so then the question will have two limbs. I'm sure you'll speak to them. So one, I'm sure you'll also share a little bit, maybe the experience with Metropolitan Hospital, how you've been using digital health solutions to unlock more value in the healthcare and what you provide, but also most importantly, just from now, the angle of the Kenya Healthcare Federation, and looking now broadly into now the broad potential that digital solutions have. Now, as we are embarking as a country into the digital health journey, what now is this broad potential that we have that is yet to be unlocked and needs to be unlocked? Over to you.
Thank you, and I'm very pleased to be here. Good afternoon. Actually, we have four hats. The first one is I run a hospital that I founded 28 years ago. The second is that I design software. So the solutions we use in the hospital bear my signature in many respects. The third is that I'm an investor in tech, because we have two embedded software companies in Metropolitan that develop solutions that are also available to others. And the fourth is KHF. So we started with a hospital, but we quickly realized that one, we were leaking revenue, and we are therefore not, we are loss-making, and you cannot run a private hospital which is loss-making. And secondly, all the issues Peter has raised with the insurance companies were something we were living through, and the solution was to digitize the hospital. And this is a journey that we actually began in 1994 and really went into it from 1999. So as we speak now, we believe we are one of the highly digitized hospitals, right from the patient process, except for inpatient, we are paperless. And we now have an ecosystem that connects patients. The presentation that was on about monitoring patients at home, we began to monitor our patients at home, and for diabetes and hypertension, and we are adding more diseases. They are connected to the hospital. They are also connected to their doctor. And we've also connected Metropolitan Hospital with clinicians. And for those who may not quite appreciate what doctors go through, patients see a doctor in a clinic. Then if you're admitted, you go to a hospital. The doctor writes physical notes in a hospital file, but needs to follow you up in their clinic. So the notes are left in the hospital, so when you appear at the clinic, Dr. CTNA has to try and remember who you are and what was your diagnosis and what prescription you got, etc., etc. So we built a link that links the hospital's data system to the doctor's system and to the patient. And we've also linked to the Ministry of Health so that the data they need is available to the ministry without us having to fill the big books that hospitals and providers have to fill. And our experience is that it makes a difference. We have 99, 97 to 100% recoveries from insurance companies for periods spanning 3 to 5 years, because our claims are able to go through Peter's systems correctly. So from a sustainability point of view, it does make a real difference when a medical facility is digitized. It makes a difference from a financial perspective. It makes a difference from an access perspective, because patients don't have to spend all their time in queues waiting for various things to be done, from pre-authorization even to payment. And I'll give you a very simple example. Payments, you go to the lab, they give you a bill, they tell you to go to a cashier, and you come back and present your receipts to the person in the lab to take your blood. But with M-Pesa and with the integrations we have push to pay. So wherever you go, you have a digital cashier, you keep paying and you don't have to go back to a cashier. If you are limping, it makes a huge difference. And for patients who are discharged, it makes a huge difference that there is somebody monitoring how you're doing, and if your parameters are not quite there, they can call you back to the hospital. It makes a big difference from a quality perspective, because we are able to do peer reviews between doctors, nurses, laboratory people, radiologists, and see outliers. And during COVID, we actually picked that a particular doctor had much better outcomes than the others. And that doctor became a trainer for everybody else, and we even began to collaborate with level 6 hospitals all over the country to discuss COVID care. It was possible because the data showed that you are much more likely to survive when you are being looked after by this doctor compared to the rest. So, access, quality, cost, all those factors that we talk about all the time in UHC model are addressed by digitizing. But from a national point of view, and we too are moving into AI, and I'll pray for Peter here that now that NHIF is allowed to outsource their claims management, that he will be very far ahead in the queue, because I would want to see my money in 2 days if that claim process is outsourced, as opposed to the current situation where you have bills going back to 2017 that are yet to be paid. From a national perspective, it is absolutely fundamental that we have data portability, and I'm sure you covered that, because the issue Peter has alluded to, where somebody is going around with a prescription, if all healthcare providers were connected, then I would have an idea about the treatment a patient has had prior to coming to me, and therefore make decisions. Because a patient, we are from birth to death. We are not a point of data. We are a video, we are a movie. We need to know somebody's history from birth to the point they are now, so that we can make good decisions about their healthcare. But many times, we take pressure today. We take sugar at the point when you are getting care. And making a decision on the basis of this one reading is a problem. Because it could be that somebody is going through stress, and you increase the antihypertensives. So data portability is key, so that we have patients porting around with their data, giving incentives to organizations to digitize the environment, because if the facilities do not digitize, then there is nowhere to port the data to, is key. Training providers, because one of the key challenges we have is providers who want to operate analog. So training them and showing them real life cases like the one I have seen about the value that data brings on board is key. And if we are going to achieve our UHC goals, we need much more capacity in the industry in terms of people who can develop and support solutions and analyze the data. AI is key, because if UHC succeeds, and it has to succeed, we have to make it succeed, we are likely to be north of 200 million claims a year. There is no way we are going to process those claims through manual forms. We won't have trees, and we'll need an army of Kenyans, just going through these claims to process them. So in every respect, access, quality, and cost, there is no alternative to digitization. And I'll add one. The Pharmacy and Poisons Board does not do a good job in pharmacovigilance, right? Knowing what is happening to people post dispensing of medicine. We know up to the pharmacy. After that, you are on your own, to a very large extent. Whether you are taking the meds or you're not, whether you are suffering from side effects and you're not, we don't know. Digitization offers us a solution to bridge that last mile, because we can give solutions that remind patients about their medication. We can give solutions that allow patients to give feedback how they are getting on therapeutically and whether they are experiencing any side effect. So from where I sit, There is no escape. There is no alternative, and KHF is very, very keen on digitization. Many of our members are here. We have a whole digital healthcare platform. It's our most active committee. The second most active is healthcare financing, for obvious reasons, that we need money and we need to use it properly. And there is no alternative but using digital platforms to deal with fraud and to ensure that we are getting quality. And finally, we usually have a lot of debates. In an industry where you don't know, you buy a Mercedes because that's a car people know. One of the reasons the use of generics is low is that if you cannot do pharmacovigilance, if you cannot verify, then the safest thing is to prescribe the brand that you knew, the innovator molecule, and that becomes expensive. So digitizing means we can get comparability about hip implants, about medicine, and we can therefore pick cheaper alternatives that work as well. Thank you.
Thank you. I think that is a very also rich experience around the value that even and also the recommendations that you are offering around that. And now to move to Pamela, and coming from now the Reproductive Health Network, you are actually also you have a platform, that Nena na Binti platform, that you've been using to enhance access to comprehensive HR information and services to young people. Now, just also speak to experience around that, but also importantly, with broadly now the recommendations now, what are some of the values now that you'll see these bringing on board, and as we are also moving again to the UHC, what will be some of the recommendations just from the experience that you've been utilizing the platform at Reproductive Health Network? Over to you, Pamela.
Thank you so much, Tim. As you've heard, my name is Pamela Adhiambo. I work with Reproductive Health Network Kenya as the Advocacy and Communications Officer. So if you do not know Reproductive Health Network Kenya, it's basically a network of healthcare providers who are committed to offering comprehensive sexual reproductive health and services and information. We are present in 43 out of 47 counties. So we have healthcare providers all over the country, and we have just not gotten entry points into the SL counties, but we are yet to get there. So we work with clinicians, mid-level providers to gynecologists. All those people are around our network. To Tim's question, I'll start with who Nena na Binti is. So Nena na Binti is our toll-free line, and it basically means speak to a girl, for those who don't understand Swahili. And it's a toll-free line that provides SRHR information and offers referral for services, especially reproductive health services. And it is 24/7, and it is handled by a trained counselor. And to why Nena na Binti, and this hotline was launched back in 2020, and we were seeing cases, SRHR cases rising. So I'm sorry, I'll not bring in a lot of the health system part. I'll bring in more of the community and young people issues and how we have been able to approach that. So back in 2020, we were seeing there's so much that young people and the community were facing. We work a lot in the community, and we were seeing a lot of issues coming up: early sexual debut, unmet need for contraception. There was lack of information. There were cases of SGBV. All these things you've heard probably in the last 2 days. But now the big thing came in, COVID, and I'm glad Daktari here has mentioned. COVID was a blessing in disguise. Let me just say that, because it really triggered our minds to start thinking, what innovations can we come up with? How can we make health services accessible to people? Because services were interrupted. There was lockdown. There's restricted movement. So at that point, we we lost connection with our community because we could not continue with the interventions we were doing at the community. So we launched the hotline to make sure that we don't have interrupted services. So we were committed to making sure that our young people have information. A lot of young people were out of school at that point, and we knew this was going to be a disaster. You're home, these cases are going to rise. So it was time to start mitigating some of these issues. So that is how the hotline came to be. And we were just there to offer a safe space, a non-judgmental space, confidentiality. You know, our young people, let me say, like myself, we need confidentiality, privacy. And we saw a lot of young people reaching out at that point. So IH&K's experience has been really good. I feel like the hotline has given us a sense of fulfillment, satisfaction, because we have been able to bridge the gap. Especially in terms of information. We are a service delivery oriented organization, but when we look at our young people, our communities, most of the things that they lack is information. And information is basically everything. Even for Daktari here, for Peter here, if all of us don't have information about what they are doing, then basically there's nothing they are doing. So for us, we were majorly looking to focus on providing information and offering this referral for our young women and girls. We have a bias, but we also get calls from even adults who sorry to say this, but adults call in sometimes to say, is this Radio Jambo? Apani, Patanisho, you know, you get such calls. But majorly we get adolescents and young people who want to know a lot of information about their sexual reproductive health. And it cuts across from menstrual health to relationships, to contraception. And you really see the need for such information being out there. So whatever we have been doing with Nena na Binti as a platform has been really fulfilling for us. And we, over the past 2 years, we have been able to reach over 86,000 people, that just through DMs, you know, people DMing you on Instagram, on Facebook. We have been able to get the calls, messages on WhatsApp. We have been able to refer over 10,000 people for services, which is a big thing, because as Daktari has said, if you are given that opportunity to reach 80,000 people, we will be doing a project for the next probably 3 years trying to reach them, going from left, right, and center all over the country. So we have been able to do this through, it's a whole cycle, because you do not want to leave your client hanging. So you just, someone calls and you just tell them the information and let them be. So what we do is basically we create awareness about the hotline, and then clients reach out. It could be either through our platforms, they have gotten the information through our platforms, or they have gotten a referral. And when they reach out to us, we try and get information from them, their data, age, who are you, your sexual orientation, because of course we have to also acknowledge that. And then they speak to a counselor who is able to get what issue they are facing, and they're able to refer them to either of our trained healthcare providers who is within their proximity. And from there they can be able to go get services. And sometimes us being in this space, if the client is not able to meet the cost, we are able to negotiate for them for a better rate. When they get the services, they're able to go home, and the healthcare provider is also able to follow up with the client to see if they're doing well. And also on our end, we do follow up with them to just make sure that the services they got was satisfactory and up to standards and quality, and to also get their feedback, because honestly, without feedback, we are not going to improve, we are not going to make solutions for them. So that feedback part is also very important. And for us, we feel like we have levelized the ground, because there's a lot of challenges we face when you talk about sexual reproductive health, issues of geographical barriers. So probably you're not in an area where the facility is within your proximity, issues of cost, issues of privacy, issues of stigma. We deal with a lot of diverse population, from the LGBTQ to PWDs, people living with HIV. So it's a diverse range of population, and we have been able to serve all these people through this platform. So for us, it has really helped us to levelize the ground and be able to serve different audiences or different populations without these barriers. So we have been able to overcome the barriers through that. And to some of the recommendations, I would say, number one, I know there's a wave. I know COVID came in, we are doing innovations, and I think sometimes people are just under the pressure of let's do an app, let's launch a hotline, let's do this. But I would say research. Who is your audience? Who are you targeting? Make sure you are making the innovations tailor-made to what is suiting your audience. So for instance, if I did Nana na Binti in a very different style, probably we will not be able to attract the kind of people we deal with right now. Number two, I would say for young people, young people love fun things, and they love having things in one place, I would say. So having everything in that one app, having everything in that one innovation you're making. So consultations, can I be able to do this, do this? Young people hate going around. You're just, when you go to the hospital and you're told, go there, go there, go there, go there, and it feels, they're very impatient and they're very, I don't know how to explain it, but yeah, you get it. You can have a one-stop shop within your innovation. Yeah. I would also say also having virtual assistants. This has come in handy really, because like I've said, our young people, sometimes the community are very impatient, and if they don't get a response within a certain period of time, they give up, and they'll probably go and mess up or miss out on a certain thing. So I would recommend that even in our innovations, make sure that you have an AI or virtual assistant who is able to keep them going, but also have a human touch, because in every little innovation we have, we also need to have a human touch. If they feel like they need to talk to someone, have a linkage or something. If you're doing a chatbot, if you're doing an app, are you able to collaborate with someone who is having a hotline, so that in case this person needs to talk to someone, they are able to call that particular hotline. So let's not feel like we need to work alone as well. Language. I don't know how to spell this. I should write it here in capital letters, because a lot of innovations we are doing, English. Why are we assuming everyone understands English? Why are we assuming everyone understands Swahili? Let's localize these innovations and make sure that even if you are able to get an innovation, a chatbot speaking to me in Luya, in Luo, in Kikamba, I'll be able to understand. There are people who read Luo Bibles, Luya Bibles, yeah? So if you also have the app, localize it to our context, because it's us, it's ours. So let's bring it to our context. Let's bring it to our community level, because everyone needs to access these services, even if it is digital.
Okay, thank
you.
Okay. Thank you. I was actually almost, I know we do have a lot of recommendations, and my timekeepers are really flashing the timeout card to me, but I really want to appreciate the panel. I think we've seen the diversity here, from offering a solution, from actually now the experience in utilizing the same in a facility, and also now the experience now offering a solution also to the communities, and some of the recommendations. And I think one thing that is coming out clearly is the kind of value that the solutions are able to provide. And I think one thing that I want to also to say, I know we have government actors in the room now, as we also as a country, and also the ministry is also plugging into these. I think there are already very rich lessons that can be learned, and also already the kind of collaboration and partnership that could be forged with people who've actually already tested and are already having solutions that are already working and can already see the potential and the value. So I would want to come back to my panel for parting shot, but I want to, because of time, I want to allow 3 questions, so that as they answer the 3 questions, they also now give their parting shot so that we don't have to come back for a Q&A. I can already see one hand is up, 2 hands are up, 3 already are up. So I think 1, 2.
All right. Let's start from...
Hi. My question is going to Peter and again at the center, because they're the ones that are dealing with digital health. Are you putting into consideration the aging population as well? Because everybody was talking about exclusivity, but they're not taking the special consideration when it comes to the aging age gap. Yeah? For example, when it comes to insurance for Peter, are you having a criteria, because most of them are excluded for insurance coverage, and then even for the digital, I want to also imagine that it also include issues to do with the wearable sensors, yeah? And then how do you translate it when you're giving when you're coming to providing the particle mitigation when it comes to the health of the aging persons? So that's the question, yeah.
Thank you. Second person. Okay.
My question goes to the lady who's talked about reproductive health. I think we are seeing a repeat of COVID, which is likely to go up. By the time January comes, we have just seen the data released about pregnancies. They have gone up. During COVID, we had a lot of teenage pregnancies. And we need to think about safe shelters. It is information that is usually left out in all the apps. And now we need to ask ourselves, where will these young girls go? Because they have gotten pregnant. We have seen the numbers that Mary is leading, and we know there are many other young girls who are getting pregnant. Again, there's the issue of a triple threat, which includes SGBV. So we need to think about shelters, safe shelters. How do we include that information in the app so that when a young girl gets pregnant, they are not thinking about aborting, running away from home, which brings SGBV and other issues. So we need to include that information about safe shelters. Where can they get information? Where are these safe shelters? And how do they get into those safe shelters?
Right, thank you. My question goes to Dr. Akombe, because I think for those, when he says it's been in existence for 28 years, I think I'm one of the clients who is half that age in that facility. And you talked about a challenge like in admissions. So probably you could cite about a little bit about what has been a challenge, because that has been my experience. I think that takes longer, and patients sometimes feel like that's an area that the hospital should invest in. So probably you can cite it as to why, because maybe it's a learning point for other facilities. Thank you.
Thank you. So as you also answer those questions, I think you can also just finalize with a parting shot now from this conversation. And I'm taking us back again just to the, now that, because we have, the reason we're having this conference, we've just come from the UHC lounge, the government now, we have this political will going on. Just a parting shot around how, like, just speak to a government. What next? What we need to do moving forward? Yeah, thanks.
Thank you. I'll start with the admission one. We actually track our admission times. We date stamp everything. One of the greatest difficulties with processing admissions is access to two things. The first is insurance authorization. It can take hours, and Peter spoke to that. We need to shorten that period so that we don't waste patients' time waiting for authorization from the insurers. Because usually if you admit somebody without authorization, the bill is likely to be declined. The second is specialists, access to doctors, right? Fortunately, we are training minimal, and so many hospitals are beginning to have a resident specialists within the facility. And anything that does not get measured usually doesn't get done. Hospitals, facilities need to be able to track access times so that you can address precisely what the problem is. And I hope I've responded to your question, because in our case, we actually get messages. I'll get messages here in the event that certain things take longer than they should. Then on the aging population, yes, that is a population we need to look after, and I'm glad that there was a conversation about NCDs, because as we get an aging population, looking after patients who require care for NCDs is key. And yes, we need to connect our systems last mile completely with wearables that are medical grade, so that you don't even have to key data into a device. We can pick the data straight off if you're wearing your wearable, and if it's off, we will know. And part of what the government is doing with community health workers, part of the care we'll need for the aging, and my parents are in that group. My dad is 98. We've just employed a nurse full-time. He's resisted for a long time, but this time he's gone home with a nurse because he can no longer manage to key his blood pressure into the app that he's provided with. And they actually need care. So we have to train our community health workers to have home caregivers. We have to think as a country about where Dr. Sitiene, I, and Wasuna will retire, because suddenly it's not going to be under the care of our children. So we need to start building nyumba ya wazee na kina mama, where care will be available right there. It's not only the young people who need somebody right there. Care will be available right there in a living environment for the age. So we have to look at our entire architecture to look after this community, because it may not be possible to have them all over the place. Finally, I want to say two things as I finish. The first is that we passed 4 bills, and I say we passed because I was also part of that journey, because there is public consultation and engagement. As a private sector, we didn't get everything we wanted. I don't think everybody got everything they wanted, and I don't think there is any law anywhere in the world where everybody gets everything they wanted. But I believe that we have a much better foundation now, not just with the laws, but with everything that has happened over the last 20 years, from devolution to internet networks and the internet backbone and the fiber optic and all the apps we've developed. We are in a very, very good place to move forward. And one of the best things that has happened, and we need to make sure it works, is finally giving healthcare facilities some degree of independence, so that a lot of the decisions can be made at the facility. The other is to link the NHIF contribution to a percentage. I want a cap, but the fact that it adjusts each year means we don't have to be adjusting NHIF contributions every 10th year through a very rigorous and difficult legislative process, because the risk is that the money is never going to be enough. Finally, the counties, because of devolution, and this is an opportunity many of us have not seen, any county that improves its healthcare system today runs the risk of tourists from another county who don't pay coming to utilize it. And therefore, governors have little incentive to raise the quality, because raising the quality means people from Kakamega come for treatment in Nairobi. By making the hospitals independent, and by making sure we are all paying through MTIBA and other platforms, it means the better hospital, the better healthcare facility will be the one we go to, the money will follow the patient, and we are likely to improve the quality of care. Thank you.
Okay, thank you. I think now we can go to Peter, and also similar with the parting shot.
Hello? Yeah, okay, great. Yes, thanks. Although I would normally say ladies first, but happy to. So I think respond to the question about the aging population. I think it's very relevant. And in fact, actually, I think the question you ask actually about like exclusions from insurance products based on age, I think is extremely relevant. In my view, it's like one of those examples where the industry has totally optimized for themselves and not for the customer. While there is actually demand of people who want to buy an insurance product at higher age, even though, and they would be willing to pay more, because it's clear that there's going to be more expenditure if you're at a higher age. And I think, the insurance industry is just afraid of doing it because they have optimized for themselves. But that's why I think we need innovative players. And, one of our partners, AR Insurance, launched on Monday morning, was part of the launch, a product called Shwari, and it doesn't have an age limit. It's considered by the whole industry. I was there on Monday morning with 280 brokers, and everyone was amazed that this does not have an age limit. In fact, the age limit is 100 years old. So actually your father can still join if he's fast. But so no, I think the industry is getting ripe for it, and I think there's a fear in the industry that the costs would spiral out of control, but this is how technology can help. And I think we all need to make a statement that we demand these kind of products, because then I think the industry will see the opportunity. And when they get the confidence that the cost can be managed, then I think we can push the industry in that direction. So it's a very relevant comment, and I think very timely as well. Which brings me maybe to the parting shot, which is maybe a connection. So I think in general, innovation, my parting shot would be we need to drive collectively as an industry innovation through partnerships and collaboration. So with, for instance, insurance companies who are taking the lead in product innovation, but also, of course, we're also partners to Access. A lot of research is being done, and very innovative concepts like the NCD one, but also public healthcare schemes like Marwa and Kisumu. Those kind of things we really need to push forward as an industry to get to learnings, insights, success stories which can inspire others. And I believe a real key to that is start small. Let's just start. Let's stop talking and let's just start and learn along the way. And we learned a lot from that ourselves at Antiba. We made a lot of mistakes. We learned it the hard way. Sorry, we spent lots of time and money in developing apps and digital things. And in fact, one of my favorite examples is that we launched a small innovative insurance cover on Matatu products earlier this year, and we wanted to make sure that we capture people's details through an app. And after one day, we discarded the app and we started to bring back paper and pen because it was too slow, and it was just much faster to hand around the manifest. So those kind of things, let's just stop talking and start doing and learn, and the market will immediately tell you what works and what doesn't. So that's my parting shot.
Thank you. Now, last but not least, Pamela, over to you. Also, response to the question and parting shot.
Oh yeah. To the beautiful lady, you look like me. You have specs like me. Okay. I would say, in terms of safe houses, I will still say or emphasize what Peter has said. Collaborations. We cannot do everything. We cannot do everything because I know for RHNK we have our areas of focus. You have your areas of focus. They have their areas of focus. So we cannot say we want to save everyone in the world. But if we are part of saving that girl, that woman, then why can't we collaborate? So if I am going to do an app, then I have to do my research, like I said. Then I look at my target audience is people who are facing SGBV. They probably need safe houses. They probably need this and this. And from that, you can be able to incorporate that into the app, incorporate that into your innovations. So I would say partnerships, make sure you map out the partners who are doing things that are aligned to what you are doing so that they complement what you have. So if, for instance, we will partner with our other partners who work with SGBV and have safe houses. So once they have been assessed by a healthcare provider, they can be able to be sent to that safe house. And I'm happy to say we also work with a very trained and capacity-built healthcare providers, so they are able to help you. Once we refer you to our healthcare provider, they'll help you through, assess you, and even help you fill in the forms, take you to the police station. They're able to follow you through that particular process, and if there's need for you to go to a safe space or a safe house or a rescue place, then they're able to follow through to that. So I would say for me, it was actually my parting shot. I was going to say it's time for us to partner, it's time for us to collaborate, because we need data, we need these data scientists, people, IT gurus, we need health people, because if they make the app and they don't have the data and they don't have the community voice, then there's nothing we're doing. So I would say partnership. Thanks.
Thank you a lot, and I'll hand it back to Steve, who will lead the participants in appreciating this wonderful panel and myself as the moderator.
Thank you. Tuwapigie makofi tafadhali. Let's give them a round of applause. Thank you. And please, Timothy just joined them for a conversation. Timothy just joined them for a conversation. Camera. Tuwapigie makofi tena. Let's give them another round. Asante sana, thank you. Very engaging conversation. And the panelists are still here. I think most of the panelists from morning are still around. If you feel like there's something that you need clarified, please make good use of these networks. At this point in time, ladies and gentlemen, we are joined by the government itself. So I would request that we put our hands together as I welcome Dr. Joyce Wamisho from the Ministry of Health. And here she comes to tell us about the digitization agenda and forging forward. Government is futuristic. Thank you so much. Another round, please. Thank you. Asante sana. Karibu.
Good afternoon. Good evening. Good evening. Doc, it's evening. When does afternoon and evening start? Okay, good evening. Maybe that is also a way of telling me be short and sweet, which is exactly what I will do. Thank you to Kelin for inviting us here. And thank you to the participants. We really appreciate. Every time we talk about this digitization agenda, one of the things that we hope is we leave ambassadors, so that you go out there and first of all start by telling people that your data is secure. And we are also working on building trust. We build trust when everything is quiet, not when there is COVID. We build trust now. The other thing I would like to appreciate is my senior, Dr. Sitienei. The work that, or the presentation that I'll be making is because I have stood on shoulders of giants like him. He's been my mentor since 2009. And a lot of the digitization vision, he's the one who actually visioned, dreamt about it, digitization at the national level. The reason why this is so is history always repeats itself. So we, as you will see in what I will be saying, this is not the first time we are doing digitization. We even have a short video that we have done. We are about to finalize it to give in the digitization journey. So digitization started a while back, and you've heard from our able doctor, Dr. Gakombe of Metropolitan, 1990. Where were you? Where were you in 1990? So I'm speaking to the converted. So I will take us a bit faster than usual. So our health sector, our health system is predominantly curative. We know about the double burden of disease. We keep on talking about communicable and non-communicable diseases. We know what COVID did to us. It tested our healthcare system. Are we resilient? We also know that, and that's something that kept on coming up from the time I've been seated here, is that there's declining donor funding, especially for the strategic programs. Our health information system is at varying levels, from the fully digitized Metropolitan Hospital to what we see in MTRH, and then
when you go to a facility like, where is it? Which facility do we? Kathonzweni dispensary. You know where Kathonzweni is? That's your area. Are you digitized? We are heading there so that we can be able to gain the benefits that have been alluded to on why we need to digitize the whole ecosystem. And then we know we have human resources and health products technologies issues. We know that in the counties, people are always striking. We know that health products are not as available as we'd want them to be. There's increasing out of pocket. We are always in a WhatsApp group, either for cancer or a kidney transplant. And then quality of healthcare, where quality is actually the individual who defines it. What I define as quality is really may not really be what you define as quality, but at the end of the day, we agree that when you go to a healthcare provider or a health facility, you want to leave feeling better. You may not have been healed, but you want to leave feeling that somebody listened to you, that you were offered the best services that you could get at that particular facility, and that whatever you need to get better or to at least enjoy a quality life, you are provided. Now, all this is against a background of increased movement of people. So now we know we don't have, we don't have gates, and our president is every day telling other countries that no visa for you, no visa for you. So more people coming in and out, increased interaction of people and animals. The One Health issues is something that we also need to bring to the forefront. Emerging and re-emerging diseases that we thought we had already finalized with, we are seeing them again. And then, you know, the ever nagging question of possible bioterrorism. So all this is happening, but yet we need to keep on referring to what our constitution says, that every person has the right to quality, to the highest attainable standard of health. And when we say every person, we submit to the parliament and to the Senate health committees. Then how are we planning to do this? So there is this narrative that keeps on going around that we have implemented UHC, I don't know, is it 2, 3, 4 times? I hear 3 times. For us who are medics or we are in the profession, we even keep on wondering what is these people are talking about, because this is something that we should be having this. It's not even about launching or relaunching. So sometimes we get stressed when we hear some of these words. But what we are saying is the implementation approach is back to the basics. We are embedding it on primary health care, because diseases are in people and people are in the communities. So we go there, try and reduce how much of disease is getting to the healthcare system. So do a lot of preventive, promotive. Then whoever gets into the healthcare system for purposes of curative gets quality healthcare. So that's the implementation approach, and that's why you keep on hearing we are shifting from curative to preventive and promotive. And this requires empowered communities, empowered people. Okay? And the pillars that we are working through are the health products technologies, the HRH, the healthcare financing, and of course health information. So this is the journey I'm talking about. There is a time we were there, paper-based system, and I know there are facilities that are still there. You send someone to get a file, they find the file, sijui it's underway, it was Nyeshowad on, rats kula that file. You can't understand. I mean, you cannot be able to even follow up a patient. Then we have hybrid, where in some corner of the health facility, perhaps there's an EMR, electronic medical record system, and then the rest of the facility is still running manual. And then we have the fully digitized facility, like what you have been explained to, like Metropolitan. So it's been a journey, and we have all these types of facilities. And then where we have electronic medical record system, we have this Madhogodhanyo kind of thing. Everything, things are just moving in different directions, but are they speaking to each other?
No. Okay. So to make this talk, it took us a long time figuring out how will all these systems speak to each other, because we have, as I've said, the automation is very low. We have multiple EMR systems. Some of them are very disease specific. Others are just now in the private healthcare facilities. Then suboptimal exchange, and then limited capability for interoperability. So what we did is come up with how are these systems going to be speaking to each other, and that is what you keep on hearing about the superhighway. So the superhighway is this metaphorical road that allows systems to come in, read the same kind of things. So that's where we have like the National Health Data Dictionary. So if somebody has high blood pressure, it is read as high blood pressure or hypertension across board. Not me writing high BP, another one writing HBP, another one writing hypertension, another, So we all must read the same. For example, we must be able to identify clients the same. So that is what we call shared utilities. So that highway is those shared health utilities, and I'll be showing that just so that we can understand. So that we don't also stifle innovation. We don't want to tell people that this is the one system that you must use. Use a system that meets certain standards that have been agreed on, and then those systems access certain utilities, what we call the shared resources, like how do you identify somebody uniquely, so that when that person goes to Garissa, they can still be identified and care is provided to them. That is basically what we are doing. So don't let someone tell you, oh, we are only going to have one system in this country, or the ones that have already been happening, because that's one of the questions we keep on getting, at least from people who have been implementing EMRs, like the HIV programs, for example. But they must connect to the shared health utilities. So we relaunched UHC. We call it Afya Nyumbani, and that is the logo. So before, one of the things that when we used to talk about UHC, and you could get everyone giving you different ideas of what is this UHC. For a long time, UHC was likened to be equals to NHIF. True or false? Did anyone who didn't, UHC is equals to NHIF. You could hear, yeah? See? So, but, and you see, that's what I'm saying. For us in the medical field, when we could hear that, we could get a bit like, what are we talking about? But when we say Afya Nyumbani, it means it's trying to mimic the implementation approach that I talked about. Embed at the primary health care, so meaning provide a lot of health activities at that level. So primarily prevention, promotion, reduce how many people get sick and get into the healthcare system, and then those who get sick and get into the healthcare system or require to get into the healthcare system, then sort them out from a quality perspective. So that is what Afya Nyumbani looks like. I think it's a very beautiful logo, I think so. Then we launched the Smart Primary Care Network. So we are doing this through primary care networks, where the base is the community. Then from the community, we have the spokes, which are the dispensaries and the healthcare and the health centers. And then the hub is the sub-county facility. So the first smart PCN, meaning it's digitized all the way up to the hub, we did it at Kapkatet. So going forward, and you will see in the going forward, is for us to have smart PCNs all over the country. There are about 315 primary care networks. We need to make them smart. So I've explained that. Then the roadmap to digitization, we did have a convergence workshop. I know several of us attended it. But what helped us is one of the
things that emerged immediately was we have not been involving certain stakeholders in these conversations, and key of the example of this is the insurance, the health insurance, the stakeholders. So we were able to say, oh, these are people we had left out but need to be part of discussions going forward. But of course, other stakeholders like academia, private sector, we've also been involving them. But one of the things that we are going forward to do is have a digital health technical working group, so that we bring all the stakeholders to the table to have meaningful conversations in areas where they are experts. Like when I was listening to the MTBA conversation, I was like, you should be in the room where the social health insurance regulations are being done, because yes, we have NHIF guys, but the things that you're saying would really benefit the team that's working on that. The health information exchange blueprint, we've already defined it and documented it. And then I've talked about the shared utilities, and I've listed the ones that are that we have, but we have others like the health provider registry. That is something that we are starting working together with the regulatory bodies. So that's the digital superhighway, but I'll not belabor on that. I know this particular section was handled very well yesterday by Dr. Sitenei, the legislation and the regulations. We have the Health Act 2017, where e-health is recognized as a mode of health service delivery. And then we have the Data Protection Act, and people like to ask, so if there's a DPA, why did you come up with a Digital Health Act? So the DPA legislates on health data that is identifiable. You know, Joyce is X years old, she's female, you know, the fact that you can identify who we are talking about, that's the mandate of the DPA. The Digital Health Act goes beyond that, so it complements what is in the DPA, but goes beyond that to legislate on other data, including the identified individual level data. So, and we know how critical that is in for us who know about data. We know that today it's not even like if I want to do any form of research, for example, I don't even need that identifiable data. I need de-identified. That if you give me that data set, then I am able to do a lot of work with it. So this was enacted, assented to on 19th October. That is the Digital Health Act 2023. And a lot of us were involved in the public participation. It is also during this public participation that we got to hear the concerns that people have regarding certain things. And that is what we are incorporating when we are now coming up with the regulations. And I know Dr. covered this very well. We also have a lot of policy documents. It's good for you to know that we are not starting from just zero. And as I said, we have been thinking about digitization for a long time. So these are very many policy documents that we've developed, and they enabled us also to really think about what to put in the Digital Health Act. So going forward, we are saying that we need to act. So we have the vision, and the vision is to do what Metropolitan has done, but in all facilities in this country. And then go a bit further, I don't know, and ensure that we can even, link up with the regulatory bodies. We can go to KEMSA, we can enter KEMSA. And then the healthcare financing, I know we really speak a lot about the national one, that is now the one that's coming up, the Social Health Insurance Authority, but other health insurance providers. So to do that, there are certain things, and one of them is to establish the Digital Health Agency that is
in the Digital Health Act, and the agency will do several things, but the most important thing is develop, maintain the comprehensive and integrated health information system. And we have to look at it from a perspective of people, processes, tools, and governance. And to this, we will not do alone. We will ensure that all the stakeholders that are that are required are on the table. Then the health information exchange. So things like the client registry that are already up and being used need to now really be used. I don't know about Metropolitan. Have you started using the client registry? Those are things now that we are thinking about. Opening it up so that we are all reading from the same script. The National Health Data Dictionary is another one. Then I've talked about the Health Workers Registry and the Health Products Registry. Those are now the next things that we are working on as a country. And of course, as I've alluded to, these are things that we cannot do as government, because we need the experts, and the experts are amongst our digital health stakeholders. And then continuous enhancement, that's one word I've learned over time. Then matters to do with capacity building. Digital literacy for Wanjiko is very important. But one of the things that I've taken home from today is we need to even band people by ages. You know, that was a really good input that I got, that if you're looking at the very young, then who we call as teenagers, and then, you know, for us, at some point, 25 years looks very young. But kumbe inside that 15 to 25, there are bands inside, and you understand things differently. So digital literacy for Wanjiko, digital literacy for healthcare workers. Pre-service and in-service, we are starting conversations with institutions like KMTC. How do they need to train health records information officers going forward, for example? And then optimize local capacity for big data management. That one was really alluded to by several speakers today. We've talked about this, and I've said we are currently working on the regulations, and once we are done, we will be inviting the different groups of stakeholders for public participation. Please come and give your input. One of the things when we were doing public participation, Senator Sifuna one day came and said, I don't like talking to government because talking to government is like talking to stones. Stones don't listen. And we had to reassure him that as we are different stones, we've got ears. So don't have that feeling. Come and insist. There are people listening, and we are going to ensure that those concerns are taken into consideration. Obviously, we have several other things that we need to do, like review and update the EMR standards and guidelines, but this will be done in the context of the Digital Health Technical Working Group that we want to come up with. And then we do all this because of the data inside that system. So we need to improve, to improve the data quality, for example, we must encourage use. And to encourage use, we must build capacity for how people look at that data. So promote a lot of people, promote people to look and review their data at all levels. So first, to improve the data quality, I can tell you this is something that we've started with the data that's coming through EACHs. There's a lot of, there's quite some Madogodanyo inside there, but that is how all data systems, that's the cycle that data systems go through. Before you reach the level of quality that you require, you need to, you need to encourage people to look at their data and then do the necessary OJTs. And this, of course, will improve quality of health services and formulation of sound policies. So I have been talking a lot for the last 2 minutes. I feel like I've been doing an Olympic run. But the main thing is we have a vision. We have a very clear roadmap. And we have solid foundation. Now we have the legislation that we kept on saying, oh, it's taken about 5 years, but the impetus to get it going really was in the last 1 year or so under Dr. Sitiene's leadership. And then now we have everything going for us. The stars have aligned. We need to act. And we all have something that we can do to ensure that this vision is met. So
These are the things that I have talked about, but the ingredients to make all those things work is coordination, and we are taking this very seriously from the government point of view. Coordinate digital health stakeholders through ICC, through technical working groups, even have a communities of practice. One of the things that we also want to start is debates, where you come and talk about AI, for example, you know, and we listen to each other and we come out with what is best for the country. Communication is very important. We can only move together when we all know where we are moving to. So communication starts with like a forum like this. And then even as we now move towards Wanjiko and all the other stakeholders, let us communicate the vision properly so that we are all aligned. Collaboration, I cannot overemphasize on this. It has been said so much in this room, but what I need to add is the word meaningful collaboration. And you can only collaborate when you're, meaningfully, when you're pulling in the same direction, not us pulling in different directions. And then continuously learning and innovating. This, I think, is one of the things that has helped us reach where we have reached. What we are doing now for the country is based on lessons learned because of digitization, either at program level, like through the HIV and TB program, or from case studies like Metropolitan and others like Kitengela, a public health facility that is fully paperless. And we are learning so much. We have learned so much to be able to be bold to say, now we can digitize the health ecosystem. So it doesn't mean that we are not going to fail. We will fail a bit along the way, but that should not stop us. We should use that to instead improve and get better at our processes. So with that, I hope you are fully convinced that we are on the right track, and do your part. Do your part. And it starts with, first of all, just going back home and explaining to people about this whole digitization process. Your data will not be seen. We will work hard to ensure that that doesn't happen, because even as it comes from the health facility, it will never come with your name. It will come with the unique identifier. At no point will the unique identifier be stored together with the main data set. There are those kind of things. And of course, we know security, it starts in the design. So we are also incorporating that, the various levels of security. So don't give up on your country. We are headed in the right direction. The stars have aligned, and we are headed in the right direction. Thank you.
Thank you. Thank you. Thank you. Asante sana Daktari for that wonderful presentation and the parting shot. Yeah, we are headed in the right direction. Tumpigie makofi tena. Let's give her another round. Okay. I feel like the energy in the room can still allow us to go for another 2-3 hours. Yes? Yes? Yes, everybody is saying yes. So, ladies and gentlemen, that marks the end of our day 2 session. Clap for yourselves. If you've made it this far, it means that it's possible, right? Say digitization is possible. Digitization is possible. Yes, it's possible. So right about now, as we prepare for the nilisema mbuzi wawili walipoteza maisha yao hapo awali. They just decided to die for the sake of us. Okay. So as we prepare for the goats and to receive the beautiful branded presents that Kelly has graciously accorded to all of us, it's only fair. You know, the journey started in 1700, right? We saw that yesterday from Dr. Sitine's presentation, right? And we have people who have made this possible. True or false? Daktari here started his hospital in 1994. And it's amazing. In fact, it's a trailblazer. People are now the MOH wants to see the model that you're using so that we can replicate the same in the entire country. So we have people who are doing amazing work in terms of access to quality health care. And we want to appreciate them. Tujipigie makofi tafadhali. We want to do what? To appreciate them. So, we have 4 different categories, and this was done through a thorough process. We have very many players in the sector. We have people doing amazing work in terms of digital health solutions in the country. So the committee at Transform Health sat down and sieved through all these partners and came up with 4 awardees. Tuwapigie makofi tafadhali. Let's give them another round. So we have the first category we are going to recognize. And please, as we do that, with the help of, yes, thank you. Thank you. Yes. Yeah, so we have the first category, which is an advocacy award for leading advocacy for using digital health technologies to address community health needs, for their commitment to educating the community on digital health and ensuring that national conversations reach the local communities. This institution has packaged global information and shared it with the community. We said that 99% of the work is where? At the community level. Silvio, please help me welcome on stage Border Hub to receive their Advocacy Lead Award. And to help us do that, I would request that Border Hub be awarded by Dr. Wasuna, please. Camera, this is now your time to shine. Thank you very much, Brother Hub. We really appreciate the work you are doing in Busia. Yes, making sure that the local community down there, 100 miles away from where we are today, get the information that we are discussing at this moment. Tuwapige makofi tena. The second in that, the second category is Service Award. And Service Award, we are awarding this particular institution for their commitment and dedication to advancing digital health framework in Kenya, for their outstanding commitment and unwavering dedication to advancing the digital health framework in Kenya. Through tireless efforts and a resolute focus on leveraging technology for the betterment of healthcare, this institution has demonstrated exceptional leadership and a profound commitment to transforming healthcare landscape. Their persistent advocacy for the integration of digital technologies within the healthcare sector has contributed significantly to the modernization and optimization of healthcare services. By championing the implementation of innovative digital solutions and fostering strategic collaborations, this institution has greatly shown commitment to digital health advancement in Kenya. Please, let's put our hands together for here, Kenya Health Informative Informatics Associations. And to help us award KPR, I would request Daktari, CCNA, kindly, please help me award KPR for their good work they are doing in service to humanity. That is Sylvia receiving on behalf of KPR. Tuwapigie makofi tafadhali. Thank you. Please, let's encourage them to continue with the good work that they are doing. Thank you, Sylvia. We are proud of KPR and the entire team. The third category, ladies and gentlemen, is a Pioneer Award. And we are awarding this particular institution for pioneering efforts to advance the use of digital health technologies in Kenya. It is with great honor and admiration that we recognize this institution for their pioneering efforts and unwavering commitment to advancing the use of digital health technologies. Through a steadfast dedication to innovation and a visionary approach to healthcare transformation, the institution has emerged as the beacon of progress and excellence in the local digital health landscape. They have demonstrated exceptional leadership in leveraging digital technologies to improve health outcomes and enhance the overall well-being of their beneficiaries. Their pioneering spirit and proactive approach have not only elevated the standards of healthcare delivery within their region, but have also inspired others to embark on a similar journey towards leveraging technology for the betterment of public health. Please, let's put our hands together for Kisumu County, Europe, the first of its kind. Kisumu County. The first county to come up with the first technology health. Yeah? Yes, I can see Director both coming. And to help us award Kisumu County, I would request Daktari, please, because you are also a pioneer. Yes? So pioneers wamekutana, sivyo? Please, let's put our hands together as Kisumu County receive the award. Thank you so much for the wonderful work you're doing in advancing digital health in the western region. We are very proud of the county and the entire leadership as the Professor Peter Anyang' Nyong'o and his entire team. Tuwapigie makofi tena. Ladies and gentlemen, all this is not possible without leadership. We could have not realized any advocacy effort, pioneering, and even service without leadership. Somebody sat somewhere and provided guidance and direction. Sinikweli. So in this category, we are going to the fourth category, which is Leadership Award. And we are going to award this particular institution for offering leadership and direction towards digital health in Kenya. In recognition of their unwavering commitment and remarkable contribution to advancement of digital health technology, through visionary leadership and parallel dedication, this institution has spearheaded groundbreaking initiatives that have significantly transformed the landscape of healthcare delivery in our nation. We applaud their exceptional leadership and commend their outstanding contribution to evolution of digital technologies in Kenya, setting a precedent for excellence and innovation that will continue to shape the future of healthcare for the generations to come. Ladies and gentlemen, this is now the time we all be upstanding as we award Leadership Award to the Ministry of Health. I would request Jessica to come for us. Jessica, I would request Dr. Wasuna
CS. Pass our regards to the CS. Pass our regards to the PS and the entire leadership at the ministry. We are extremely happy with the services that you're providing. We are happy with the leadership that you have shown. In fact, we have reiterated here 1,000 times that for the first time we saw a bill come to an act within 3 months, something that me as a policy advocate have never seen before. It means that there is a stable leadership at the ministry. Tuwapigie makofi tena. Thank you, thank you. So to wrap it up, and as I exit the stage, it's been a wonderful day and a wonderful conference. 2 days we've spent here, and now we are going back with rich information that is going to change the way we serve the people we work with, the way we address the needs in our communities. It's going to shape even the conversations that we are having with our community stakeholders back there in Busia, back there in Kisumu, back in Kilifi, and in the entire country. So please, my plea as I welcome Dr. Wasuna to make or to give us the final remarks and declare, okay, as he makes his final remarks, and then he'll welcome Dr. Sitenei to declare the conference officially closed. I would request us that let us not leave this information here. Okay? We should not leave this information here. Sawa sawa. And the contacts that you have collected, the networks that you have made, please make good use of them. Joyce emphasized on collaboration, but then she added an additional term to it, which is meaningful collaboration. Sawa sawa. With all those few and very many remarks, I have been your captain, Osedo Steven, from the Center for Fiscal Affairs. Asanteni sana na Mungu awabariki.
The story about the two goats, huh? So I should be fast. Mine was actually just to give a recap, just highlighting the key points that have been discussed over the last 2 days. I know we cannot be able to capture everything, but I'll just be able to give the key highlights in point form. And I'm sure at the end of this function, the rapporteurs will be able to share what we have in more details. So what came up as recommendations, number one, is that we need to invest in and take advantage of the available opportunities in digital health. So while the health sector, while digitization in the health sector may be expensive at the start, the costs will reduce with time. And we also need to look at the benefits that will accrue to that. Number two, we need to digitally interconnect existing county digital health platforms to an optimal countrywide solution. So this is the issue of bringing all the 47 platforms in the 47 countries. Three, we need to forge strategic and meaningful partnership and collaboration between the innovators and key actors to A, develop user-friendly versions of the legal instruments to enhance awareness and adoption, and B, in the adoption, in the testing innovations and adoption of successful products. 4, we need to have public sensitization on data protection and cyber security, among others, for more informed decisions on the management of own health data. Next, we need to focus on the people, consumers of novel or yet to be digital technologies, as opposed to focusing on the technology itself. 6, the professionals need to consider the unique, individual, socio-cultural, economic, and infrastructural factors that define the Kenyan landscape, or that define the local context. And several examples were given here, like having the virtual assistants, like for the youth, having a solution with a human touch, use of a language that is well understood. And there are so many of them. And also the issues about the aging population. 7, we need to implement human-centered design principles to enhance efficacy and acceptability of digital health solutions. This will foster increased user engagement, trust, and health outcomes. We need to meaningfully involve the youth in planning, designing, and implementing digital health programs. 9, there's an urgent need for intergenerational dialogues for more optimal adoption of the digital health solutions. 10 is the issue about areas where we need to enhance capacity. A is on digital literacy for the healthcare workers, development, enhancing capacity in the development support systems, and analytical capacity. So there are various areas that came in terms of capacity. 11 was the increased use of digitization by the Pharmacy and Poisons Board to enhance pharmacovigilance. I think that was brought up. 12 was a call for a sustainable financing of the innovations that we're coming up with. And next is more autonomy for the health facilities to adopt or to implement preferred solutions. But of course, within the broader framework of the national superhighway. And then last but not least is scalability of successful innovations to inspire adoption. I know there are many more others, but those were the highlights. And I know that we have picked some of the recommendations that we can implement on our own. But what we will need to do as a group, and I think here led by Transform Health and Kellen, is to look at the recommendations that can be implemented by this group, pick a few of them, and let's track the implementation over the next 1 year, so that when we meet, we are able to at least account for the time that we have had here over the last 2 days. And some of them I'll just mention, not in order of any priority. We talked about the documentations of the learnings. We talked about establishment of the digital health community of practice. We can start with this group. I think the ingredients are here. We have input to the public participation in the development of the legal framework for, to implement the various acts. The ministry went out and collected lots of information, and that information is just lying somewhere in Ministry of Health. So I don't know whether it is Ministry of Health or somewhere in the cloud, but there's a lot of information. And all the institutions here have the analytical capacity. So can we all join hands to be able to support the ministry when it comes to analytics? Those are just a few of what we could actually do jointly. But it will be up to the conveners to be able to look at all these recommendations and prioritize, maybe 4 or 5. And then we split ourselves in terms of roles and responsibilities, and then over 1 year we come back, so that that really becomes the start of the next Digital Health Summit, the 2024. Otherwise, it has been a pleasure, and I now turn the mic back to the MC. Where is the MC? The MC is standing between us and the two goats, so can you come? Otherwise, thanks very much for listening.
Okay, thank you. Yeah, thank you. I think I do not need to say anything else. Let me just get some few directions before I make the final announcement. Okay, so just being told the goats the goats are ready. So yes, and because I do not want to stand between you and the goats, I'll now welcome Dr. Stienei, who was the one to officially now close our convening. Then we can head over to the place where the goats are. Dr. Stienei, thank you.
I think team has a way of ambushing me every other time. With all protocols observed, Dr. Wasuna here, my great colleague and friend. Most of you don't know that I was in class with Dr. Gakombe. We suffered together the same years, but he chose to go to the private sector. Akina Dr. Joyce, Wafula, the people who prepared this conference, great colleagues, friends, good evening. Mine is very short. I'm not a politician of any shade, so you can be sure that it's going to be very short. First is to thank the organizers. I think they have done a great job. What do you think? Please, let's clap for them. Number 2 is to thank those who are awarded, including myself. Please clap for us. Clap for yourself for participating also. Great people. Kenya is a great country. And Kenya is on that runway, basically ready to take off. The takeoff is going to be determined by you and me, particularly those of us who are implementing in the field. I'm gratified beyond words to note that communities, counties have started to see and realize the fruits that can be born from digitization of the health system. People fear the unknown, but I think when you hear the success stories, you realize that the initial investment could be recouped very fast. You've heard from Dr. Gakombe that there was pilferage. You heard from Dr. Gadasha that the numbers went up more than twice. And of course, that is also money. So when you look at the long-term end, the benefits not only outweigh the disadvantages, but it is far beyond what we can achieve. And therefore, I know the preachings which have taken place here, like Jesus said, when the sower went out, the seeds fell on the road. You know what happened? The ones on the road, they were trampled on. Others fell on rocks. They did not even, you people don't read the Bible. They did not even germinate because they were eaten by birds. Others fell where there were some thorns, they were choked. But I believe here, it must have fell on fertile and rich soil. Amen? Amen? And therefore, as we live here, we are convertees, we are converted. Let us be the great apostles, that we are going to preach the good news that Kenya is going to take off and that the benefits of digitization will make us move much, much faster towards achieving the aspirations of universal health coverage and the aspirations of our Constitution 43, Article 43(1)(a), so that all Kenyans have a right to the highest standard of health. That is possible. And of course, we must thank the government, and particularly His Excellency the President, for spearheading this noble cause. And nothing can stop us except ourselves. So as we live here, let us not only just go and preach, but I pray that Timothy will arrange for a bigger conference so that we can reach out to more people. But beyond that, may you have a lovely end of the year. Even as you enjoy your Christmas season, may you think about digitization, because it is real, and start having devices like mine. But do I say, God bless you and Merry Christmas and Happy New Year. Thank you.
Thank you a lot, and I think nothing useful to add. This is the time for you to find out whether the goat was real or fake. But yeah, thank you. So I think as we leave, maybe just a few announcements. We still have tea served here. We will be dinner will be served from 6:30 at Choma Restaurant. It's downstairs. I think we'll just be here to be able to direct you for those of you are staying. But I think for this time you can take some tea, feel yourself, eat a lot, leave the Choma for us. Okay, so you can have refreshments. We still have some goodies for you. So as you are moving around, you will get something from Pauline and Trevor, and also you still have you can still take photos. I think the MC for today was really encouraging us to be able to share, preach the good word has been said. So we still have that we can use for photos. You can still do that and share the good word. So thank you. And
as we're giving out the goodie bags, if one of the items inside is a shirt, so if you are medium or an extra large, you come to me. If you are if you are a large, or which other size? Oh no, mine is double XL. So Yeah, so double XL and medium is me. Then XL and large is Trevor. We're good?